Namrata, David was asking me, when will Aios come back to February? By?
Unlikely to come back to February, but will come back to March.
Or to
April,
March?
yeah, 1 month we are shifting. So APO
That's what I
we
said,
are
David.
going to be holding.
Your audio is gone, Namrata.
Sorry. APO, which we are going to hold in Delhi in 2025, will be in the first week of April. So we are slowly coming back, but we can't come back in February now because our financial year is till 31st March. So for the same conference, people are not going to fund twice. So it has to be beyond 31st March only. It will be April now.
Okay. Always
Because
it'll become April.
1 year in COVID. No, we lost 1 year of finances in COVID. So now it has to go after, because in India, the financial year closes at 31st March. So it will be after 31st March only now. Although we are trying to come back to,
Can we start, Namrata, now with you?
Yeah. So are we live?
Yeah, I don't know about that.
Okay. Okay, so welcome everybody to this third Aios International Ophthalmic Conclave. This is the third in series post-COVID, and we have on board 21 international societies with us over a 3-day period with more than 150 faculties and speakers who are going to be talking. Today is the last day, and I will be sharing a video with you on the same.
Namrata, audio is not there.
So thank you so much, everybody, for coming on board on this Aios International Cataract and Refractive Surgery session. And it is my pleasure to invite Dr. Steve Ashenoff to give his talk on OVDs for flax and an unusual flax case.
Okay, thank you, Namrata. I'm just going to share my screen. And then I'll start this. Okay, hopefully you can see it now. So, as you all know, OVDs are among my favorite topics. I want to talk to you about OVDs for flax, how it's from other cases, and then what happens if you get an unusual problem and how you have to adjust. The idea is that to help illustrate how I choose OVDs in different kinds of cases. So let's get going. So the first thing I want to do is review Argentinian flag sign because it's related. So this is a problem where you have numerous people coming and giving ideas of how to do it. But if you look at it carefully, all of the ones that work had to have the same idea, and they all are based on fundamental rheology. So the problem with Argentinian flag sign is that there is constant pressure because the muscles pull backwards and we don't paralyze them anymore. And we always use topical or intracameral anesthesia. And if you really have a true hypermature cataract, it's a liquid necrotic mature lens, and it behaves like a fluid, and it will not prevent transmission of posterior pressure anteriorly, unlike a solid will. So if you're, let's say, on the ice in Canada, it's stable and the floor doesn't move. But if you're on water, it's wobbling the whole time and waving. It makes a very big difference. And so when you have a hypermature cataract, if it really is hypermature, it acts like a fluid surface and doesn't prevent transmission of posterior pressure. As a consequence, if the anterior capsule is convex anteriorly, which it generally is, it will always tear peripherally on a fluid surface, the same as a balloon will tear peripherally if you puncture it. And so the answer is to take a very viscous elastic OVD, like Helon 5 or something like that, and to put pressure in the center of the front of the lens so you make it concave instead of convex. If you make it concave, it will then tear inwardly. So everyone either increases the pressure in front of the capsule or reduces the pressure by puncturing the capsule in some way to neutralize this pressure so that we can deal with Argentinian flag sign. So the brief summary is, here are 3 illustrations. So the one on the left shows you that the first dent, that little red line, it really isn't big enough, because if you make a bigger capsular rhexis, you're going to go beyond the edges and you'll be on the bowing of the capsule again, and it will still tear outwardly. And you see the drawing in the middle where the red arrow shows the center, and the purple arrow or the blue arrow shows you how far out you want to depress the lens. So that if we really have a fluid capsule and a fluid lens, it will depress it and allow you to do the rhexis without a problem. And then on the right, you see an illustration of one being done on a lens, and I use Vision Blue. And I also like to use a needle for these cases because the needle won't elevate the incision, and so it won't leak. And so the OVD will stay in. So then the question is, why did I show you that? Is FLAC similar to a hypermature cataract? Well, in some ways it is. A hypermature cataract has necrosis of the lenticular contents, but FLAC's cases has gas in the capsular bag. And the gas in the bag will inflate it somewhat similarly to a hypermature cataract. Not exactly the same, and I'll show you why. The first thing is, why is that a problem? When we first started to do femtos, there were publications about increased rates of capsular tears. And there was the whole thing from the ASCRS talking about this and saying that it was 10% in the beginning, and then it began to go down. Publication, even in 2015, when we've had it for a while, said that even then, we were getting 8.3 times as many capsular tears with femto as we were getting with regular phaco. And how do we solve that? Well, I wrote a paper in the Canadian Journal a little while ago, and I'll tell you what I did and how I show you how to solve that. So the first thing you have to figure out is, how do we look at this with respect to physics? What are we actually doing and what's the problem? Well, simply put, the problem is because of the pressure created by the laser-produced gas, and it pushes the bag outwardly, and we have to compensate for that somehow, or else when you pull the capsule, it will tear outwardly. And so on what basis should we choose our OVD? Well, the first thing you have to think about, this is not quite the same thing as Argentinian flag sign. We don't really need a very, very highly viscous OVD because we're not going to elevate the incision. We're not going to tear all the way around. We're just going to get a few points where it's stuck. But we do want a thin cannula because the capsular flap may be anteriorly and hard to get in front of. So Helon and Helon GV, for example, come with thin-walled cannulas, 27 gauge, and I like to use them. There's another new OVD that makes noise about having a thin-walled cannula, but it's 25 gauge, so I don't find that one as good. And I use to inject it either through the side port or the main incision, whichever location has a flat capsular flap and not an elevated flap. You don't want to inject under the flap, or you're going to push it anteriorly and make the whole thing more difficult. So here are 2 cases, and you can see here that there is this crescent where the capsular flap is separated from the exterior part of the flap. But here on the left side, it seems to be attached. But as I inject the OVD, you can see this is coming apart slightly, which tells you that one is probably okay. But now if we look at this other one, we have an opening and a separation of the capsule inferiorly and to the right, but doesn't seem to have come apart or worked at all. And these bubbles tell you that they're not coming out through any opening in the capsule. When I inject the OVD, you can see it didn't move. There is no crescent here, and so it did not separate. I like to use these Haldane-Perkar masket forceps because they have a very sharp tip, and you can take and you can push posteriorly and centrally and pull the capsular edge in. Jim Gills taught us this because he always did his capsulorhexis by pushing the capsular edge posteriorly, not anteriorly, as most of the rest of us always did. And so there you see it's done, it worked, it's perfectly fine. Okay, these are the Haldane-Perkar masket forceps. You can see over here the tiny tips they have, which are sharp, and you can push back the capsule very easily. And then you have this hinge, which ends up being an incision. It makes it very easy to use those. I'm sure there are other types that are similar. These are the ones that I use. I also like to use Akko Hoshi's cannula because it has a smaller tip and it's rounded so you don't damage anything when you inject gently to free up any residual adhesions. Okay, so here's a case that was a problem, made me think differently. So in August 23rd of last year, this patient came in to do bilateral, I always do bilateral, cataract surgery with femtosecond laser. And in the second eye, the right eye, I hadn't even fully depressed the laser pedal, and she moved fairly violently, and the laser turned off, everything stopped. And what I was left with was this picture, where I had a bunch of bubbles in a circle, but there was nowhere that the capsule was freely perforated, which means I basically had one endless long postage stamp adhesion of the capsule to the peripheral capsule. So that was kind of upsetting. And I began to think, how should I deal with this and not have a problem? And the reason you have to think about it is because this is not really like a flax case. It's unlike it because the incision will have to be open to insert a forceps to manipulate the flap in this case, not usually happening in flax. And there's no intercapsular gas and no areas of elevated flap. It really is much more like an Argentinian flag sign. So here I want to use Helon 5, deepen the chamber, press down on the capsule, and perform a Gillesian type capsulorhexis, and that way it'll get along much easier. So here's what I did. I injected Helon 5, put some xylocaine below it, took those forceps and wanted to see where if it was free on this place where I was going to turn the rhexis. And then I took a bend needle, cut it, and as I went around them with those little forceps, I freed up every part before I pulled the capsulorhexis around. And this whole postage stamp structure came apart beautifully, and the case went along without any problems. So the point of all this talk is physics wins. If you sit and think about what you're trying to achieve in terms of physics and not what you were just taught to do for a regular case, you will do better. And the summary is that think of the physics when you're going to do this. Use pressure equalized cataract surgery. For Argentinian flag sign or a barely started femtosecond capsulotomy, pressure equalized surgery with Helon 5 works best. For an incomplete femtocapsulorhexis, you want to use the flax OVD press with Helon GV, or a similar OVD with a thin cannula so you can get in front of the capsule. They're not the same, but think of what you're looking at when you start. Thank you for inviting me, Namrata. It's a great pleasure being here. I look forward to hearing the other talks.
Thank you. Thank you so much, Steve. You always come out with something, innovative, something new, and yet again, this is a new concept. Thank you so much for introducing this concept. And thank you for joining it at midnight in your country. Really sorry about this. Anybody would have any questions, or we can move to the next talk?
Steve, excellent talk as always. Just a thought, I think, sure, you pointed out about the physics, but in such a situation, would it not possible to waste a LOI and maybe dock again because nothing has happened, and maybe enlarge the size of the rhexis and go ahead and just try it again with a femto? Would that be, apart from the economic cost involved, I think that's a possibility that we do in case we lose the suction early on. So we can increase the size of the capsulorhexis. If it was 5, we can go to 5.3 or something like that with a fresh LOI.
You can do that, although I'd rather do this.
Okay,
the problem with redocking and changing the rhexis size and getting a new thing, it's the same patient. And
yes.
What if the patient doesn't stay still again? This way I know how to deal with it manually. It's no different from an Argentinian flag sign, and you just go ahead and do it and tell the patient, look, it didn't work well. We'll do it a bit differently. It's fine. and you sort of rescue what you tried to do the first time. So I've tried what you did say and 1 or 2 patients, but I like this better.
Okay, sure. Just a thought I wanted to share. That's
It's a good thought, and it's really I have the same position sometimes.
okay.
Yeah.
I think, sir, we can invite the next speaker now. It's none other than Dr. David Chang, who is completely needs no introduction. And he's going to be talking about light adjustable lens, LAL, which we have been hearing for last so many years. And he's going to tell us what is the latest now. Over to you, David.
All right. Well, thank you very much. Yes, the theme of this symposium was what are you doing differently? And since it includes refractive IOLs, I thought I'd talk about this because in the United States, this has really grown quite a bit in the last year. So I do consult for the company as well as some other IOL companies. Well, you know, we still have the same obstacles with the premium refractive lenses. You know, we don't achieve LASIK-like outcomes. We have the risk of side effects from diffractive lenses. Surgeons not always confident that we can satisfy the patients. The patients have trouble sometimes understanding the value of what we're doing, and therefore you're not going to have word of mouth. And this is where the LAL, light adjustable lens, I think really makes a difference. I think the concept is well known. It's a 3-piece silicone lens, but it has these molecules that basically are polymerized by a certain wavelength of UV light. So this treatment polymerizes them and it sets up a diffusion gradient so that you get very precise changes in the curvature of the lens. And this is done post-operatively in the first few months. We've been using it since 2019 when it was first launched, but this was right before COVID. Like everything, things slowed down. And that's why I say the company now has ramped up, and offices all across the US now are starting to adopt this. Unlike in Europe, when it was introduced a decade ago, we can adjust cylinder as little as a half and up to 3 diopters post-operatively. So this is extremely important. You can lease the equipment for about this much in US dollars per month. And the lens itself is like a trifocal lens or an EDOF lens in terms of actual cost. Basically, it's though standard cataract surgery, except you're just putting in what looks like a monofocal lens. And then after some period, you then do a refraction. And most importantly, you get the patient's input on do they want their focus closer, do they want mini monovision, and then you make the adjustment using this light delivery device. It's not a laser, but it's done simply in the office. And the patient in the United States is, of course, paying the premium for the service and the technology. It's really like doing a YAG laser. It's totally painless, and the treatment might be for a minute or minute and a half. You program it onto an interface, and you don't really see anything, but this is showing just how precise at a 10 micron level accuracy you can make a change in the shape surface of the lens. One of the biggest advances has been a clever way to create a UV blocker both on the front and the back. And so it's basically a chromophore that you then unlock with a wavelength, and then you do your treatment, and then it shuts down. So what this means is you no longer have to worry about UV light changing the lens. Prior to this, people would have to wear UV glasses indoors. Well, you know, the argument is, do we really need this? Because, you know, we have new IOLs, we have better biometry and all these great formulas. We can do 8K with a femto, we have intraoperative aberrometry. And you have to realize that these are good technologies, but we're really just improving the batting average, the average. It doesn't eliminate the standard deviation. And if you're that one patient that's off by a diopter, you're unhappy. This study from ESCRS's registry, I think, really represents the real world, published in 2018, you know, nearly 300,000 eyes. And what they're basically saying is 1/4 of the patients did not land in that 1 diopter landing zone, which is plus or half a diopter of the target. So we don't really do that well in the real world for the type of precision we want. So the reason it doesn't eliminate the standard deviation is you still are estimating the effective lens position, posterior corneal astigmatism, and your SIA. And then you add the more complex cases that we have in terms of IOL calculations, post-refractive, poor biometry, unusual axial length, and then the hard contact lens wearer who, as you know, their cornea may take quite a while to go back to its native shape. Same argument. Do we really need it for astigmatism? Well, in addition to these two problems, we also have corneas that sometimes are irregular. They're unpredictable. If you do AK, no matter if you do it with a laser or not, you'll have a variable effect and potential regression, and toric lenses can rotate. So, like everyone, I'm very pleased with our results. We have the best multifocals we ever had, the EDOFs. And these work great, particularly when you have all three of these conditions. This is a patient that really hates glasses, so they're willing to accept some trade-offs, and everything is perfect, and their personality and their expectations are such that I'm confident we're going to make them happy. But this means that there's a whole bunch of eyes that are not good candidates for multifocals. And I list them here: the large pupils, eyes where you cannot afford to reduce contrast, post-refractive, any abnormality, even subtle abnormality with the eye. And then a big category is refractive lens exchange, because unlike our cataract patients, they are accustomed to excellent quality of vision. They just don't want to see, have to wear glasses. And then you have these patients that just have expectations that are going to be hard to meet. I mean, if they've never worn reading glasses because they're a low myope, don't expect to lose that. And if someone's doing contact lens monovision and never wears glasses,
Have we lost? No, David is David, you're muted. David, you're muted.
sorry, how about now?
Yeah,
Yeah.
perfect.
Okay, sorry, what happened? Okay, so moving on now. So what in our practice, we certainly use the multifocals, the EDOFs a lot. And then it's just a nice complement. So it doesn't, it's not redundant.
Can
and
you
where
share
do
your
we use
screen? Your screen is not shared.
Okay, thanks. All right. I will, something came on in there, so I will go back. Be right with you.
Not yet.
I hope the earlier part was recorded. We should be okay there. All right.
Oh,
All
perfectly
right.
fine.
Yeah, we were
Yeah,
here.
thank you guys. So we basically this is a complementary technology. So the people that will use this on are certainly people that are committed to contact lens monovision or mini monovision. These are people that don't want to wear glasses, but they demand the best quality of vision. All right, so the perfectionist. It's really good for people, they don't mind distance glasses, but they don't want to wear reading glasses. And this allows you to get them satisfied with the least amount of myopia necessary, so that you don't blur the intermediate and distance so much. Obviously, the post-refractive eye. And then what I was saying before, these are the toughest patients, refractive lens exchange, people that just can't decide what they want, and people that are unusually demanding. If you think about how we succeed with contact lenses, we know that monovision is very popular. There's no unwanted image, good contrast, and you can solve everything with spectacles. And in most surveys, this continues to be a lot of our patients with monofocals. The challenge, though, is they're not happy unless you have emetropia in at least one eye, and we don't know how much aniso they can tolerate, and even if we did know, we can't hit it accurately. It's very hard to reverse. And if the patients haven't done this, they don't understand it, they're anxious, can I tolerate it? Or worse yet, they've been wearing hard contact lenses for decades and they just don't expect to need glasses. This is why we're successful with contact lenses, because we can change it. We can make sure one eye is emmetropic, and we don't have to guess what they're going to be happy with the amount of myopia. And you don't really have to explain it and have the patient understand it ahead of time. You just show them and they can decide they're happy. So this is really powerful. So if any of us were going to have, let's say, a monofocal lens, you can just select which eye is the distant. You can reverse it. So we'll typically target a little myopia and then increase it or decrease it. What's really important is for patients that are indecisive or very compulsive, you're basically saying, we're going to decide everything after the lens is in your eye. And you can show people what you're going to do. They don't have to understand the terminology of monovision. And this reduces their anxiety because you're not diminishing quality and they can decide what's sort of the best compromise for them. So you can use it, an example. If you said, I really like I don't want to wear glasses in the distance. Well, a lot of us might be happier with a tiny bit of myopia. And for those of us that say, I don't want to wear reading glasses, how do you know whether you would rather be -150 or -250? I don't think any of us ourselves know, because we've never had an IOL in our eye. And then when you correct the astigmatism, the patient can see this. We basically post-op can demonstrate different amounts of myopia. Then you do it, you wait a week, you let them try it out. So this is just like soft contact lenses in terms of a very high satisfaction rate with low risk. The key, I think, is to do these eyes very close sequentially. It is ultimately a refractive procedure. We've all learned a lot from Steve Arshinoff in terms of the safety of immediately sequential bilateral cataract surgery. I think our refractive patients, this is when normally sequential surgery is nice, because the patient essentially gets to try what we're proposing in one eye and then deciding do they want the same thing or something different in the other. But when we've been doing the bilateral, LAL, we've been doing or offering it to everybody to do it on the same day. And most people choose that because we no longer have to test it out. We're going to be able to adjust it post-op. So I just wanted to, I know this is not yet in India, but I do think it's something that's been really valuable for all of us doing refractive IOLs.
Thank you, David. I think there are going to be questions. Anybody would like to ask any questions regarding this?
Can I ask one question? Kumar?
Yeah, please, Kumar.
Hi, David. Nice to see you. Great talk as usual. I was just wondering, when you said it goes through an RKI, so the RK scars don't interfere with the laser on the application on the lens?
That's a good question, because you're focusing and it's not a laser, but it's the accuracy of a laser, but it's simply a UV light delivery system. And you're focusing actually on the IOL. So the cornea is highly defocused. So the other question is, what about capsular opacification? If you have an overlapping capsular rim, and that again seems to be okay. So the RK scars, and RK, we all have learned, you wait actually 4, 5, 6 weeks even until it's truly stable, and then you do it.
Thank you.
That was great, David. We had a session a few days ago with ISRS talking about the best modern equations and what's happening with accuracy. And the talk I like the best was Jack Holliday's, who bluntly comes out and lists all the things we do that are inaccurate, no matter whose equation you use. And the advantage of this technique is you're treating the eye as a black box. You put the lens in, you have a black box, measure the refraction, you can correct it. So I think it really offers us an advantage. And as time goes by, perhaps more and more of us will go to that, unless we get better equations and better measurement devices.
Well, that's a really good point. And, because it's still basically the patient's brain when we refract them is determining the best fit. You know, if you have asymmetric astigmatism, it's still the patient's brain that determines the best fit. So the accuracy is one thing that you allude to, but I think the thing we don't think about as much is how much indecision people have and how much anxiety that drives them. Because hitting the target assumes that the patient really understands what they want. And we've all been there when we give them what they asked for and they realize it's not really what they want. And so to be able to change it is, I think, invaluable.
So from what I understand, toricity cannot be incorporated into it. So can you do it with the toric intraocular lenses also, or only with the spherical lens?
Yeah, no, it is a toric correction. It is the most accurate toric. In the United States, we do not have a T2 or a ZCU 100.
Okay.
So, but this we can correct a half diopter of cylinder, which there's no commercial toric lens that goes that accurate. So it is toric. We can correct up to 3 diopters of a cylinder. So if you had someone that needs a 4 diopter correction, you know, but that's pretty unusual. And even if you do, I mean, what do we do when the RK patient has a ton? You know, as long as you get most of it down, as you know, their corneas are multifocal anyway. And I think one of the interesting things now is we just have the IC8, the small aperture lens available in the United States. And I still think I would do the LAL. And then if you need a small aperture, just give them a miotic, you know, such as Vuity or anything, and you can create the small aperture and have the adjustability as well.
Okay. Thank you so much, David. Thank you for your time and for your contribution, and for an odd time for you also. So I think, sir, we can move to the next talk, Dr. Mahipal, sir.
Yeah, I think Amar is next, right?
Yeah,
So
Amar is next.
Amar, one of the most proficient surgeons and somebody who's most innovative out of India and very influential as regards the world ophthalmology. Over to you, Amar.
Yes, thank you very much, Mahipal. I hope it's on full screen now.
Yeah.
Okay. So this was a patient who came to me from Iraq. And if you see in the beginning, I'll just show it to you at the beginning. So when this patient came to me, the patient had flown to Iran and had phakic IOL, anterior chamber phakic IOL done, flew back to Iraq, subsequently developed endothelial decompensation, as you can see here, cataract, synechiae, glaucoma, and the works. So the Iraqi doctor had referred this case to me, and I thought, first, let me take off this epithelium so that I can see better. You'll notice there is peripheral anterior synechiae on the anterior segment OCT. So I thought, okay, now there is a glaucoma there, but this is a closed angle glaucoma. So my next step was to take off the phakic IOL. I thought rather than enlarging the incision, I'll cut it. So I bisected it, and you can see here, half piece removed, remaining half removed. Now, the next step for me was, there was a membrane present on the pupillary area. So what I thought, I'm going to take off this membrane. The problem I didn't realize while I was peeling off the membrane is, I must have peeled off the capsule also. But anyway, I didn't realize at that time. But when I started doing my cataract, I couldn't find the anterior capsule. Anyway, I used an endolimiter because the visualization was a bit hazy, removed the cataract. I thought, let me put a 3-piece IOL inside to be safe. And to my dismay, you can notice the IOL was in the vitreous. So immediately I made my scleral flaps. You can see I've got a trocar AC maintainer on the top right-hand corner. I'm making my 22 gauge sclerotomy. Now, luckily for me, the other haptic is still out of the eye. So I don't have a dropped IOL, but one haptic is in the vitreous cavity. So after I did my vitrectomy, I do the handshake technique. So I'm using 2 hands, in other words, 2 glued IOL forceps, transferring from one hand to other till you catch the tip of the haptic. I pulled out the first. Now I go in for my, again, handshake technique of the trailing haptic, transfer it to one hand to the other, go in through the second sclerotomy, catch the tip, and pull out. So far, so good. Now I make my Chariot's tunnel with a 26 gauge needle and tuck my haptics inside. Now my problem was, you notice I have to make the pupil small. So I decided to go ahead and do the single pass 4th row pupillasty. Here you can see I've done one side and I continue to do the same. But notice carefully on that right-hand corner, there are peripheral anterior synechiae. I'm trying to break that because I know if I don't break that, the air will not remain in the anterior chamber because obviously this needs my PDEC graft. So I decided to take it off clearly, and in the bargain I messed up and I've created an iododialysis now. Now my problem in iododialysis is, how do I repair it? We started this technique, which is a modification of the hangback technique of Michael Snyder. You're fixing a trocar opposite the iododialysis. This is the trocar assisted iododialysis repair. Take a double-armed Prolene needle, pass through the iris, and pass through the sclera. You see, luckily for me, it's in the area of the scleral flap, so it will get buried. Now I pass the second. Again, notice it goes through the iris. From the other side, I pass a 30 gauge needle. Now, railroad the two. Once you have railroaded the two, bring that needle out. Now you have got two loops. All you need to do is pull. So when you pull, the iododialysis gets repaired and that suture automatically gets buried under the scleral flap. The problem is when you do this, the iris gets pulled to one side. So we have to do the twofold technique. In other words, combine it again with the single pass 4th row pupillasty and thus make my pupil good. And now notice the Purkinje image, bang, centered. It is P1 on the center. I shift it to air now. Now I do a take off my descemetorexis. And once that is done, I use the PDEC technique, which we always do, because the advantage is we have 25 micron only. We use only young donors below 40, and it can manipulate very easily. So here you see I've created the type 1 bubble, dissecting it, injected trypan blue so that it stains. Once the graft is there, all I need to do is inject it inside, unroll it, and you can see the case completed. Now, this is the patient post-op day 1. I was very, very happy because the graft was clear and attached. Now, remember, this patient has come all the way from Iraq. So now 1 week post-op, I am breaking my head and I'm seeing the patient is still counting finger 4 meter. I have to send him back. And then to my dismay, I'm realizing, why is he not seeing? Because the mistake had happened was there was an AC phakic IOL, perhaps somewhere I have made a mess in the IOL power calculation. So now I am in a mess because that patient is not seeing at all. So now I've taken this patient back 1 week post-op. After doing the glued IOL, after doing the 4th row pupillasty, after doing the pinhole pupillasty, and after doing PDEC. Now my fear is the PDEC. The rest I can manage. So now I carefully fix iris hooks. Now I have to take off the glued IOL. You notice now I made a scleral tunnel incision. I did not want to make my corneal tunnel incision because it will be large. I've taken out one haptic. Now I've dislodged the second haptic. And remember, there's a PDEC graft inside also. Now I'm using my handshake technique and I have to very carefully and slowly explant that IOL without damaging the PDEC graft. If that PDEC graft detaches, I'm in a mess. Here you see now I've taken the fresh IOL with the correct power. Again, you can notice my handshake technique. Again, externalizing the haptic and tucking it in. Now my problem is, again, I have to do vitrectomy, as you can see me doing. But more important, now I have to do my 4th row pupilplasty. Till now, my graft is okay. Touch wood. So I'm just praying like hell to hope the graft remains. Now I go in for my second 4th row pupillasty on the other end. And you can notice here, see that graft there? It's attached, but that gave me a heart attack, to be honest to you. But once there, I said, okay, I'm now not going to experiment more on this. So now I've got my second 4th row pupillasty in track. This small iris problem, I will just chop it off. And you can notice now, most important, the Purkinje image P1. Watch the inverted image, that is P4. So don't worry about it. The P1 is bang centered. The graft is still attached, and that's just 1 week post-op. Now the question is, I just injected air to be on the safe side, applied my fibrin glue, closed the case, Now question is, how did the patient behave? Look at the patient now post-op 6/12. So this was the pre-op PL. 1 week post-op, I did everything there which is possible, but patient was not seeing because of IOL power miscalculation. Again, did an exchange of the glued IOL with 4-throw velocity and completed this case, and touch wood, send the patient back to Iraq. Thank you very much.
Thank you. Thank you so much, Amar. I think that was a really challenging case. And challenge also was the IOL power calculation, but really very well managed. And it's difficult to do a IOL exchange with a endothelial graft, PDEC or DMEC, whatever it is. But I think PDEC that way will behave much better than DMEC because it's a splintered graft and chances of detachment of a PDEC graft are far less as compared to a DMEC graft. So thank you so much. Dr. J.S. Tityal has also joined us. Thank you, sir, for joining. And I think we'll go to the next speaker. If there are no questions, anybody would want to comment?
I just want to know that did you not have graft detachment in the post-op period in this case? How was it in the post-op?
Because on table, you see the graft did not detach. So post-operatively, it was fantastic and packed off the patient. He's very good, touch wood. But I don't think it's because of me. It's just the person on the top who helped me. Because to be honest, I should not have made that mistake on the IOL power calculation. That's unforgivable.
I just noticed one thing that after your video, everybody on the screen was smiling. So that in itself speaks a lot.
I think it's
Amar, just one question, with so much of manipulation, 2 surgeries, what was the posterior segment like OCT, macular OCT?
That is okay. I checked that because when the patient was not seeing counting finger, I thought the problem is in the retina. So I have this Nidec Mirante which goes through a pinhole pupil and I can see 163 degrees of the fundus. So I checked the fundus, OCT, everything was bang on track. And with this Nidec Mirante, it's fantastic. It's a scanning laser ophthalmoscope. Then it hit me suddenly, hold on, there is retina is normal. Then why is this man not seeing? And then it hit me on my head and I had to break my head for that how could I make such a stupid mistake?
So wasn't a refraction done on the post-op days?
It was done, no, but it was a bit hazy. So by the time the cornea cleared, I was so happy seeing the graft. Okay. So by the time the patient not seeing, I'm wondering why is he not seeing? But in 1 week, I realized that I missed this IOL power.
Amar, you should have done that case with an adjustable lens.
Yes. I don't know whether the adjustable would have corrected that much spherical aberration which I had created.
That was a good one. Thank you so much, Amar, again for that wonderful case.
Thank you, Namrata.
Thank you, everyone, for wonderful discussions. It is my pleasure now to invite Dr. Mahipal Sachdev, who's been the past president of All India Ophthalmological Society and the chairman of the IRSI, who would be giving his talk on laser cataract surgery for posterior polar cataract.
Thank you very much, Namrata. Always a pleasure being here. I'll be talking about the use of femtolaser-assisted cataract surgery, which we have done several studies on in posterior polar cataracts. As we all know that posterior polar cataracts pose a challenge because of pre-existing weakness in posterior capsule, and that whether how efficient a surgeon we are, that doesn't matter because there is in a significant number of cases a weakness of the posterior polar cataract. Now, what happens is that if you do a cortical cleaving hydrodissection, that in itself can cause a hydraulic rupture of the posterior capsule. And as we have understood the anatomy and things about the lens and the cataract surgery, I think we have recognized this problem and we are coming out with newer and better modalities to deal with this. Now, the femtolaser-assisted pneumodelineation that happens, that actually eliminates the need for doing any fluid-assisted hydrodissection or hydrodelineation, and therefore you don't have a rupture of the capsule that you can have. Also, there are other things that have been described because concentric rings or segments that have been described, the segments that you make, that would simplify the nuclear removal because there is a disassembly that has already happened. Now, we all know that whenever we are looking at a posterior polar cataract, these are the basic things that we have to look at, and we have to work on a closed, stable chamber. The fluidics need to be slower rather than having very aggressive fluidics. You should use the anterior segment OCT, both in the OPD as also in the femtolaser system. the perfect capsular access that you have, that would be a boon that you have, because you can place the lens in the sulcus and when the posterior capsular rent happens. And the hydro procedure should not happen because if you are not doing a femto, then whatever hydro procedure you have to do, it should not be a dissection but a delineation. And you should try to preserve the epinucleus till the end, so that works as an epinuclear cushion. Now, what I am just wanting to show you here is that we are working and we are seeing as to the anterion now. We are working with the anterion as to whether the anterion will pick up the same as we do on the OCT that we have on the femto laser. This is the catalyst system, and you can see that this is the defect that is thrown out pretty well. And you have to customize the offset so that the epinuclear cushion comes at this area, and you are able to therefore work with an epinuclear cushion right to the end. So this is the same case. You can see this is a pre-punched out, very clearly seen, punched out posterior capsular defect. And these three bubbles that you have, you are increasing it so that you have a good epinuclear cushion, maybe about 1,000 microns. And that blue area was the area where the nuclear disassembly would come. So you are leaving behind a good epinuclear cushion in this particular case, as you can see. So essentially, when you're doing a femto laser, you see whether this is a continuous, this is a discontinuous. So this is the difference you can make out when you're doing the OCT, and when you are taking it, you take the bubbles up and see that the bubbles would leave behind an epinuclear cushion. Now, this has been described by various people as to the application of anterior segment OCT to identify eyes with posterior polar cataract, and as to how you can see. But till date, this was way back in 2015-16 when our article was published. We were the first to identify the use of the femtosecond laser integrated anterior segment OCT to actually detect the pre-existing posterior capsular end. And this we found was greatly specific and sensitive that we could see. Now, this is another case. As you can see, we are going ahead with the OCT image that's coming up. You can see this is pretty good, and just watch for the posterior capsule, and this is the defect that you have. So we'll be taking this up, leaving behind a good epinuclear cushion, which we will disentangle right at the end. And you can see that this is a we are having the capsulotomy, which is a good capsulotomy. I tend to have a 5.2 capsulotomy rather than a 5. This is the nuclear disassembly that has happened, and you can see now we have done no hydrodissection, no hydrodelineation, and you will be able to see that the nuclear disassembly is really easy because there is the pneumodissection and the delineation that has happened. So you can see that this is the second quadrant that is being taken out. The posterior polar cataract is shining at you without actually doing a rotation. You can pull out because most of these polars are softer cataracts, and you can see I'm disengaging the nucleus so that the epinuclear cushion is still left behind. So all the four pieces that were there have been easily removed. And now what we will do is that we will, with a low fluidics, we'll try to take out the epinucleus through the phacoprobe itself. Maintain a closed chamber, put in viscoelastic, as you will see, without taking out. Viscoelastic has been put in, and then we are using the irrigation aspiration. You can use a bimanual, which some people consider could be safer. But now you see it is only at this particular point that the huge rent which was there, which we identified on the OCT, came. And we can close the case by putting in a 3-piece. There is no vitreous loss as such, so we are putting in a 3-piece lens in the sulcus and not in the capsular bag, and that is which will help you because we always keep a 3-piece lens standby in polar cataracts, and you can see that we can complete the surgery pretty well. Now, this is another case that I'll wish to show. This was published in IGO. This is the imaging techniques, various imaging techniques that you can use. The slit lamp and a retro illumination on a slit lamp is really fantastic for you to even find out whether there is an onion world appearance, whether there is a pre-existing defect. And you can see that there is no doubt even on the slit lamp that there is a pre-existing defect which is there. Now, when you even go to the IOL Master 700, you can pick up the same on the IOL Master 700, which is there. This is the picture that you get, as you can see, on the surgery. And when you get this picture on the surgery, this is the default setting that you have taken up. This is the microscopic integrated ASOCT. If you have one, this you can see that there is this defect, but the epinuclear cushion is preventing the vitreous from coming out. And when you actually do the entire cortex being removed, this is the integrated OCT image. Again, you can see that this is the blob of the vitreous, which is continuous, which you can see. So the femto laser can therefore help you in giving perfect incision, the architecture, closed stable chamber, and there are no fluctuations that you have. As I said, that the capsular axis, if you have a perfect capsular axis, it's a boon if things go right and a blessing if they don't. So if you have to put it in the sulcus, a perfect capsular axis, as you can see here, can be great, and you can get well-centered rexes. The second important thing is, the third important thing is the nuclear softening. As you have pre-chopped the nucleus, therefore, the nuclear rotation may not be needed at all, and you would be able to take it out. This is what was described by Abhay Vasavada, and that is the concentric rings that can be made, and femtodelineation is better than hydrodelineation, and this can be taken out very easily because of the pneumodissection that is there. Pinning the epinuclear cushion right to the end, this helps you pretty good, and posterior limit of nucleotomy can be raised from the normal 500 microns to 1000, 1200 as to whether there is a pre-existing defect. Visualization is very, very accurate on the OCT, except for white cataracts where you cannot see the posterior capsule. And nuclear rotation can be done because of the pneumodelineation that has happened without disturbing the posterior capsule. So finally, what I'll wish to say is that the use of femtolaser, the ASOCT in the femtolaser, and soon, I think within the next couple of months, we will be telling you about the results of the Anterion, whether we can pick up with the same accuracy on the Anterion pre-existing capsular defects or not. And this is like an airbag which can help you avoid fatal injuries of a nuclear drop, etc., that you have in posterior polar cataracts. So, as even if I have to pay myself, my definite procedure of choice for posterior polar cataracts, where the slit lamp is indicating, or the OPD and ASOCT is also indicating that there can be pre-existing rent, would be to go for a femtolaser assisted cataract surgery because of the various safety factors that come in, and we can get absolutely these are results which have been described, that the PCR rate in flax has gone down from 36% to 4% for Abhay, Osher 26%. Tityal has, Dr. Tityal is there, they have reported that the safety levels go very high, and they enhance the safety in posterior polar cataracts. So friends, to sum up, I will say posterior polar cataract, though a nightmare for even the most experienced of surgeons, I would say that the femtolaser and the ASOCT within the femtolaser can really help you both to identify and to do a safer surgery for posterior polar cataracts. And this provides the much needed safety cushion. And I would say this is possibly the way forward for all polar cataracts. Thank you very much for your kind attention.
Thank you so much, Dr. Mahipal sir. That was really very enlightening about the posterior polar cataract. And I think I would also like to acknowledge Dr. Mahipal sir for this webinar and for this International Ophthalmic Conclave, which was actually started during his time when he was the president of Aios, and he was the one who really encouraged webinar mode as far as the Aios is concerned at all levels. If anybody has any questions, otherwise we can move to the next topic.
I have a comment. Mahipal, I think that's fantastic. I've been doing also all the posterior polar cataracts that way, and it is phenomenally better with the femtosecond laser. The only thing I do a bit differently from you is I try to keep my capsulotomy to 4.6 millimeters. And the reason is I generally try to capture the lens if there is a real hole in the posterior capsule. And if you make the capsular axis a bit bigger than 4.6, 4.7, it doesn't capture as well. And you can capture it nice and tightly if it's only 4.6. And it doesn't matter what you set it at. And so why not? So that I think makes it a bit easier.
Yeah, Steve, I think that's a great point. Why I prefer a slightly larger capsular axis is for the nucleus to be able to come out. So basically, if you have a very softish cataract, it won't matter. But this thing is because you have fragments, so getting it out of this thing. But your point, I take it well, and maybe next time I'll possibly maybe follow that depending on the grade of the cataract that is there. Great, thanks.
I agree, it was fantastic. We all did the same.
So, Dr. Chityal sir, would you like to comment on it, since you have published a lot on this?
No, Dr. Mahipal has presented so beautifully the entire aspect of posterior polar cataract. I think one important thing he highlighted is good pre-op assessment. It may be a examination by slit lamp, as he showed a beautiful picture, retroillumination picture, and the anti-segment OCT assessment also pre-op will directly help to program the surgery accordingly. If even you are doing a manual surgery, manual phaco, or a femtosecond added advantage is there. It gives you everything in a closed chamber and pre-delineated and softened nucleus. And surgery becomes absolutely safer with the femtosecond laser device. Beautifully described, sir.
Thank you.
Thank you so much, sir. Now it is my pleasure to invite the next speaker, Professor Jeevan Singh Tityal, Chief of RP Center of Ophthalmic Sciences, All India Institute of Medical Sciences, which is also my institute, and I can vouch that he is the most supportive chief we have ever had. Always very supportive, at least for all the people in the center. And he's also the advisor to the Government of India, Ministry of Health and Family Welfare, and he would be talking to us about management of white cataracts.
Thank you, Professor Namrata, and thank you for a kind invitation. It's my pleasure to be, in this August gathering in today's webinar. I think we had a beautiful talks before me, and I'm going to take something through the white cataract journey where people can take some important points to make things simpler and safer. No financial disclosure from my side. We all understand we do a white cataract. Two things are worrying for most surgeons. One is how to manage this white cataract in terms of getting a good capsular access, mainly because we are worried about the increased intralenticular pressure, which is going to really take the rhexis in a different manner. Like this is a patient where we have a central pout, and this is going to have increased chances of a rhexis going to periphery. Like you can see here, it is going to periphery. So how do we going to prevent this disastrous initial venture into cataract surgery where capsulotomy, capsulorhexis is the important part of surgery to complete in a nice manner? I think in that way, the slit lamp examination is one of the most important aspects to delineate the type of white cataract, where you can see the anterior bulge of anterior capsule. You can see the shallowness of anterior chamber. Also, you can see the intralenticular clefts and pockets also if you do a good high magnification slit lamp biomicroscopy in your cases. But most importantly, the same thing can be picturized, imaged in anti-segment OCT, where you can see the fibers which are hydrated, and intra-fiber, intralenticular pockets can also be assessed, and the curvature of a lens capsule can also be assessed. These two examinations will definitely give you the type of white cataract you are going to face and what all complication you might face and which has to be encountered in a proper manner. These ultrastructural morphology can also be seen in IOCT, that is, that Dr. Mahipal talked about, the anti-segment OCT attached in the microscopes, which not only picturizes as you see in anti-segment OCT, this also gives a dynamicity of each step of a surgery and what happens with this particular step. And especially in a white cataract, the anterior capsular puncture, the integrity of a capsule, release of fluid, and the convexity going to concavity can also be seen. The dynamics will be visible in a white cataract. So that is what we picturize in these cases. You can have a spectrum of white cataracts, right from the totally fluid-filled cases like a type 4, which is like a hypermature or a Morganian cataract, to cases where you have only hydrated cortical fibers and you have a below integrated clefts in these cases. So these pictures can give you idea what type of procedure you're going to do to decrease the intralenticular pressure. There are various techniques have been described by many surgeons, right from the needle puncture to YAG capsulotomies to micro punctures and name like you can have a puncture with a phaco or a probe as such. And those things can only be justifiable if you have this picture in your mind by doing an anti-segment OCT or IOCT picture, then decide what step you have to take in these cases. Like this is case one where you can see the OCT picture is the convexity is not that much, and you have a uniform, you can say minimal intralenticular clefts and uniform flattening of anterior lens capsule can be seen once you do a puncture. There is no leakage. So no point this case taking for a needle aspiration, nothing will come out because the pressure is not high in this particular case. The surgery becomes simpler as normal case. This is another group of cases where you have OCT gives you a picture. You have a convexity which is higher, and you have a length of a cortical fiber going from across the length of an entire lens, and all the clefts are below this hydrated cortical fibers. Their needle aspiration may not help in these cases. These cases need to be done a bimanual aspiration of a cortical fiber. So like you see after puncture, the entire cortical fiber, they dome out like a tsunami, and this will definitely cause a raised pressure radiating to the peripheral area of a nick of a capsule, and extension may be very, very high. To see the same in a video here, the same patient here, as soon as we make a nick in the capsule, the entire cortical fiber bulges out. The intralenticular cleft doesn't go off. The pressure still remains. So these are cases needle aspiration may not help at all. Here you have to do a aspiration. Make a small opening first. I've done a 1 millimeter capsular opening, then do a bimanual aspiration of a thick hydrated cortical fibers to be taken out. The entire convexity has become concave. The pressure has gone down. You can do a nice capsular access in this case and complete your surgery. This is a type 3 where you have a both hydrated cortical fibers and the clefts also. And as you make a nick, the fluid is going to release and surgery can be simpler. You can see the entire thing has got flattened here after aspiration. You can use needle aspiration. You can do any technique here that will decrease the interlenticular pressure. You can see here, same, as you make a nick, the fluid leaks out, the convexity becomes concavity. I'm pretty sure my capsular access will be simpler and easier and complete in a one go also. So this is how important it is to know what type of fluid you are seeing in your patient. So this is type 4, where you have an entire capsular bag is filled with fluid, and as you make a nick, entire milk comes out and pressure goes down. And these cases, again, are high-risk cases because there is no support from behind for tearing the capsule. So sometimes you may have to fill the bag with a viscoelastic to have a capsular access support, or you shift the nucleus to one side where actually tearing, and that will give a good support for your case. Femtosecond laser, as Dr. Mahipal talked about, posterior polar cataract, it's also very, very helpful in the white cataracts also. This also delineates the anterior capsule and subcapsular area. You can see the entire ground glass appearance. This is a full of fluid. As soon as you make a laser, that's going to relieve the pressure also. So femtosecond laser devices are always better because there are no chance of a radial extension of tear because everything is getting released in a closed chamber. So that's the advantage going to face using a femtosecond device for a white cataract also. This is after laser application. Now shifted the patient to OR. You can see the fluid has come out. Only you're left with the cortical fibers. Everything is flat. So you can easily do phacosurgery in these cases. So you can classify your white cataract based on an examination, anti-segment OCT or IOCT microscope, then decide what type of case you have, and then plan how to decrease the interlenticular pressure and do a good capsular access or capsulotomy by laser and complete your phacosurgery also. So what I have been doing new in the last few years, I do pre-op OCT for every white cataract patient, apart from the good examination of these patients, which will definitely help, like assessment of these cases. Then I would decide the management of increased lenticular pressure based on my IOCT microscope imaging. Then see what is the dynamics of anterior capsule, the dynamics of anterior chamber, the release of fluid, and the cortical fibers. Then decide the approach and complete the surgery in appropriate manner. Thank you for a kind listening, and hope that we'll see physically very soon.
Thank you so much, sir. Thank you for that new concept, totally a new concept on how the white cataracts behave, which is possible through your beautiful videos. and through your beautiful surgeries. If there are any comments or questions.
I would say fantastic, Dr. Tityal, for actually real in vivo pictures and images as to what it is and trying to describe the morphology of the white cataract and how one should deal with it. I think it's a fantastic learning for anybody as to how to deal with the problem of white cataract, because these are problems which even the best of us should put in our best to kind of give excellent results to the patients. Great.
Thank you.
The next talk is going to be by Dr. Mohan Rajan. Is he here? Sujata? Mohan is
He's there. He's there.
Okay. So Mohan is going to be talking about IOL implantation in the absence of capsular support. And thank you, Mohan, for being there. I know it was a little difficult for you, but thank you once again.
I'm not well, so thank you very much. I'll share my screen now. And are you able to see my screen?
Yes, Mohan.
Yeah, thank you, Namrata. And thank you once again, the Aios, for this wonderful opportunity. And today I'm going to talk about the IOL implantation in the absence of capsular support. So, as you know, early recognition combined with advances in instrumentation have enabled effective management of posterior capsular rupture during phacoemulsification. So, when you have a PCR, you're always in a dilemma what lens to be put, whether to put the lens in the bag or the lens in the sulcus or an AC IOL or a retro-fixated iris claw lens or an SF IOL or a Humana technique or a glued IOL, which we are commonly doing now. And look at this video. If you see this video, which is taken a long time back, and there is when you have a PCR, please don't pull out of the eye. That is one of the important messages I want to give here. So when you pull out of the eye, what happens is, what is a small PCR becomes a very small PCR, a very big PCR. Are you able to hear me now?
Yeah, perfectly.
Sorry, my bad throat, and I also had a surgery for my back yesterday. So this is a bimanual IA, which once you have a PCR, always go bimanual. That is, remove the vitreous first and then remove the cortex for later. So the nucleus has gone there, and you pray to God. Sometimes the nucleus will come up like this. And then what is more important, I want to tell, I think this has been covered by Sujata later in the talk. You can see here, I have just removed the cortex and the first vitreous and then the epinucleus in the cortex. And see, since the capsular excess is intact, so go for a multi-piece lens. So this is a sensor multi-piece lens, which I implanted long time back. And still the patient is doing well. And since the capsular excess was a little bigger than normal, I couldn't capture this optic. So it's always aim for a slightly smaller excess if you're especially dealing with posterior polar cataracts or even hard-blown cataracts for that matter, because they're expecting some PCR at that time. So just to show you that how to do what is called the drop-down technique of the trailing haptic into the bag, make sure that sometimes when you do the drop-down technique or when you try to dial the lens, you can go behind the capsular excess and you can find the lens on the retina next day. So make sure that it's there. And just to show you that, this is another patient. You can see here there's a small PCR at the end of the surgery because of the post-occlusion surge. This is again a video which is quite a long time back it was taken. Again, a bimanual IA I'm doing, but most important, you can see here in this particular case, wherein I just put there's a small PCR. I was able to, restrict the PCR because I injected Viscoat and came out of the eye and went ahead with the MA60 lens in the bag, and the patient doing well even after 20 years after the surgery. So at that time, only the MA60 lenses were available. These are just post-operative pictures. Again, you can see another patient. This patient actually is a gynecologist from Kerala. You can see here, she came for a toric lens. The lens started sinking into the, it's quite a brown cataract, but you can see the toric mark also on the cornea. And once it started sinking, I did what is called an anterior assisted levitation of the lens. And that is not thing which I wanted to show you here. Once you bring the lens up, making sure that you put viscode there, okay, viscode there, and then try to remove the lens similar to what I am doing for SSCS, and then go ahead and do an anterior vitrectomy. And I can see here this patient, I was able to put an MA60 lens into the sulcus. So make sure that you see the sulcus very well. Sometimes the pupil becomes small and you don't see the sulcus as well. And that is again very important when the pupil becomes small during the PCR. Again, you can see another patient with the posterior polar cataract, and you can see here bimanual, there's a pre-existing dehiscence of the posterior capsule. Again, a bimanual technique, always put preservative-free tricot. But this is a thing which I wanted to show you. You can see the two typical pillars on the posterior capsule were very typical of a pre-existing dehiscence. If you put a lens in the bag, there's a possibility of the lens getting dislocated into the vitreous. So what I'm trying to do is I'm putting the lens, the MA60 lens, or any three-piece lens for that matter. You can put it in the sulcus and capture that optic into the, it's called the optic capture. You are locking the lens, and you can see here, the locking the lens is very, very important. So you can see here how the locking of the lens, making sure that the lens is, the optic is in the bag. This prevents the long-term decentration. The lens does not move a micron. And the end point of the locking is that there is an ovalization of the anterior capsule. That is the capsular excess margin, which is again very important for us to understand. Once you lock it, then the lens is as good as in the bag and doesn't produce any UGH syndrome and doesn't move a micron. You can see the post-operative pictures, 2 months, 9 months, 2 years. This patient is almost 5, 6, 7 years now, maintaining a vision of a good 6.6, but also the lens is also well centered as well. Again, if it's a small PC tear, you can convert that into a posterior capsular excess. This is very, very important. Many people try to put a lens in the presence of a PC tear because what will happen is, if you have a small PC tear, what will happen is if you try to put a lens without converting that into a posterior capsular excess, then it will start extending, and there's a possibility of the lens getting dislocated into the vitreous cavity. Always convert that into a posterior capsular excess margin. You can see here, I'm putting an in-focus lens into the bag without any problem, because the posterior capsular excess is as strong as an anterior capsular excess as well. Again, another patient, you can see here, how what I'm trying to do is, I noticed a PC tear at the end of the surgery, and the video is not very clear, but very soon it will become. So you can see here, this is the PC tear. You can see the PC tear. The problem is this PC tear is extending all the way up to the equator, and you cannot convert this into a posterior capsular excess. So I went ahead and injected viscode there, and every time you come out of the eye, when you have PC tear, inject visco, and you can do a bimanual IA, and making sure that you think this. Fortunately for me, in this case, there is no vitreous there, and you can see there's a PC tear. It's like a triangular shape there. But what is important is I'm putting an SA60 lens into the bag. You notice that PC tear. You can see here, this is what I want to give the message. What is that PC tear? Once I put that SA60 lens, I'm gently putting the lens in the back, and see how the PC tear is extended there. Fortunately for me, the lens was stable, and this is what I think I want to give as a message. Again, a patient with the femto, femto is not all that thing, making sure this patient had in the initial cases of the femto, when we started the femto way back in 2017, you can see here how it's a hard brown cataract. The message I want to give here is that the patient had a PC tear, and you can see here, once you have a PC tear, the pupil becomes small. Take that extra time to put iris hooks, okay? To iris hooks. Why you want to put iris hooks? Because you want to make sure that you removed all the vitreous and the cortex. More importantly, you want to see the sulcus very clearly, okay? You want to see the sulcus. See how I'm putting the lens in the sulcus and making sure that the lens is in the sulcus. Otherwise, if you have a small PC tear and with a small pupil, and you will not know where the lens is actually going. You feel it's on the table, it's decentered. Next day, you will find that it has gone all the way down. Again, another patient with anterior assisted levitation. People, this thing is not going down. If it goes down, of course, you cannot chase the nucleus. And I'm just trying to put an anterior vitrectomy. And this, I think, Sujata will be talking about. And in this case, old patient, I just went ahead and put a ACIOL. Only thing is ACIOL, the sizing of the lens is very important. Making sure that vitreous is not there in the anterior chamber, the pupil is round. Make sure that you don't forget to do a PI in this patient. And the patient did very well. Patient had very old patient, had cardiomyopathy. So this patient is actually doing pretty well. Again, you can go in for an iris claw lens. Or how much time I have, Namrata? More?
It's 8 minutes, but you can complete this.
Yeah, iris claw lens. And I'll see that scleral fixation. I think not many people are doing scleral fixation, but still it is one of the gold standards. But what we are doing more of glued IOLs nowadays. All these things either you can do as a primary procedure or as a secondary procedure. After a couple of weeks later, you can leave the patient awake. Then you can assess the patient. Basically, at that time, you do not know how your adrenaline is flowing. You cannot think properly. Just to show you how the glued IOL, how to take the 180-degree flap, you can use an anterior chamber maintainer. Amar has devised a beautiful thing called the trocar anterior, the TACM, the trocar anterior chamber maintainer, putting the sclerotomies and making sure that you remove the vitreous, remove the capsular cortical remnants from the pupillary area, and you can go ahead and do what is called the handshake technique, catch the tip of the haptic and bring it out. Everybody knows about it. And creating the Gabot Shariat tunnels and tucking that lens into the thing and gluing the flaps as well. So all these are, of course, the Yamane technique. We are not doing that Yamane technique on a regular basis because the simple problem is the Yamane technique. There is a possibility of the pseudophacodonis is a little more because you do not know exactly how much of the haptic is there inside the thing. And of course, the Canabrava technique, I just borrowed this from Canabrava, of my good friend Sergio Canabrava from Brazil. But more importantly, I think you should have a plan A, plan B, plan C for all these patients. So you can either go for ACIOL, retro iris fixated level, sutured scleral fixation, glued IOL, Yamane, depending on whatever the capsule is there, the remnant of the capsule is there, and the anterior capsular is whether it's intact, sulcus IOL. Or if you're not able to do it, leave the patient aphakic, and after a couple of weeks, probably can examine the patient on the slit lamp and then go ahead with the implantation of lens according to what was this. Sometimes the capsular margin can fibrose and you can put a lens in the sulcus very easily later. Thank you again, Namaskar Aios, for this wonderful opportunity in the patient attention. Sorry for my bad voice.
No, thank you so much, Mohan. Thank you for being there. For those excellent videos. I think I'll now invite the next speaker, Dr. Kumar Doctor, who's going to be talking about intraoperative meiosis.
Hi, Namrata, and hello to everyone, and thank you for this opportunity given to me. I'm going to talk a little bit about iris behavior in surgery. Can you see the slides?
Yes, yes.
Yeah. So it's about iris behavior intraop. So this is the first case when we do bimanual IA. What I want to show here is just look, when we go with irrigation on the right side and start the IA, the iris suddenly pops out of the wound. So it's a very simple trick. What I did is put the iris back and then shifted the irrigation port with a different direction in the on the left side. And the iris does not come out. So this is just a simple take-home message that sometimes you have to just change the flow in bimanual IA that prevents the iris from popping out. So this is one part that I want to say. Now this is a vitrectomized eye, and look at it, I put a ring inside and suddenly the ring comes out. Now a vitrectomized eye and a Malugan ring behave very differently. So here we have removed half the cataract, going ahead and doing phacoemulsification. I put a Malugan ring inside, holding on to the iris. And when I go in with irrigation, because it's a vitrectomized eye, suddenly the pupil will dilate. We know this, right? So this happens. But if we don't use this, sometimes many attempts will be taken and then the pupil dilates and then the whole procedure can be taken. So in this case, I had actually put in a Malugan ring, gone ahead and then going ahead. So now let's go with the phaco probe inside and see how it actually looks. So when we go ahead, I've engaged all the 4 loops onto the iris. Half the cataract is out. And now I'm going to go with the phaco probe and see how the whole eye behaves. So you can see that some of the loops come off because the irrigation has gone in, and again it disengages and it can come out again. So the iris behaves very differently. The anterior chamber dynamics is very different when the eye is vitrectomized and you have a malignant ring inside. So this can happen quite often. I just wanted to show this part of the video, that this one has to be a little careful. Sometimes you may even put a little bit of pillow carpet to make sure that the iris actually gets engaged onto the loop, and this will prevent all this from happening in the future. Once that is done, you can see that I'm going ahead with coaxial IA, going ahead. Sometimes the CCC gets entrapped into the loop of the malignant ring. If that happens, we just make sure that it is disengaged and then go ahead and put an IOL in the bag. So this is a 3-piece IOL going into the bag, and the malignant ring is then easily removed. The most surprising thing that can happen sometimes is the intra-op meiosis. That is what I want to show in this video. Now you can see this is enough pupil, a 5.5 millimeter pupil, not a very hard cataract. I have stained the anterior capsule to show that yes. Now I'm using a dispersive viscoelastic on the pupil. Sometimes this prevents the pupil from coming in, thinking that I'm a good surgeon, I'll get away with this, but just see this case, how the pupil really behaves. Sometimes this can happen. So I'm just trying to show that if this happens, what is the way out? So here I'm putting a little bit of dispersive viscoelastic on the pupil to maintain the size of the pupil, making sure that it doesn't come down during my surgery. A 5.5 millimeter looks adequate for surgery. Going ahead, and now we start with phacoemulsification after the rhexis. Once the rhexis is done, we start with phaco. Now, as I said, this is not a very hard cataract. It is a reasonably soft cataract, just going around. Sometimes if they become a plate, then it becomes even more dangerous. But here I'm able to bury the tip inside, do a phaco chop, and then separate, and then go ahead. At this stage, I feel, yes, everything is under control. You can see that the iris is trying to come out through the side port, and a little bit of iris is trying to come out through the main wound. In that case, still, I feel I can manage. Everything is going fine, nothing much to worry. I'm getting a little bit of grip. At this stage, I feel everything is under my control. If this happens, then what to do? So now you'll see the next few seconds what is really going to happen. In such a scenario, so this is what I call intra-op meiosis. During surgery, the pupil tries to come down. What are the precautions that we have to take? What care we have to take? And how can we escape a complication in such a scenario? So again, as you see, it's a soft cataract. Vacuum is a little high. We can reduce vacuum. If it is a brand new tip, the nucleus tries to fall back. Then normally I like to reduce the vacuum and use an older tip. So here, in the next few seconds, I'm still getting a grip on the cataract. I'm trying to separate, trying to chop, and make sure that it goes ahead and we can finish this case. A 5 millimeter pupil technically is sufficient to be doing safe phacoemulsification. But now you will see, even in slow motion, that when I'm going ahead and trying to hold on to the nucleus, one part comes out, and this gives me a lot of confidence that yes, it's completely under my control. So again, I'm holding the nucleus, making a little chop, and getting one small pieces of the nucleus out, and everything is fine. That's it. So now you saw that at one step, I just held the iris. Luckily, no phacoemulsification, but now the shape of the iris in that area, because of the pull, it completely changes and it tries to come down on you. So this is the danger part, and I'm still trying. And then again, I thought, okay, this is still manageable. It's not all that bad. So why not come out and put a little bit of more dispersive viscoelastic to get a little bit of more space, and then go ahead and do safe phacoemulsification. I'm trying that, but when I come out, you'll realize that the pupil still comes down. So if this happens, it may be wise sometimes not to go ahead. You can see that now again, I'm putting a dispersive viscoelastic, thinking that it will hold on. My CCC is intact, 5 millimeter, 5.5 millimeter CCC is sufficient, thinking that this will still work and go ahead. But as time goes by, I realize that it's getting more and more difficult, and the pupil still comes down on me. So now what are our options? We can go ahead and put hooks, we can go ahead and put a Bhattacharya ring, or we can go ahead and put a Malugan ring. But one thing is there, that once we've done a CCC, to put in a Malugan ring is even more tricky, because sometimes the loop can actually engage the CCC. So here I realized that now the pupil is further coming down on me, and the area of phacoemulsification, the area of chopping where I need to actually apply all the forces onto the nucleus is actually getting covered by the iris. And if it becomes a plate, the case will become even more difficult. So here I'm going ahead, and now I've decided, no, this is not great. And you can see that I'm going ahead and putting a Malugan ring onto the iris to hold. Now this will change the whole scenario. So once I put the Malugan ring, it's very, very important to make sure that the CCC doesn't get into the loop. I'm getting a good exposure inferiorly, but temporally you can see this area that the CCC is not seen well. So most likely I'm engaging the CCC margin onto the loop. Now this gives me enough space. As you can see, visualization has drastically improved. So I feel that all these rings, hooks that are things are necessary in your armamentarium for doing safe phacoemulsification. Even though we have a good size rhexis, sometimes it's necessary that intra-op the decision should be taken that this accessory tools will use and be useful to us in our surgery to give safe results. So here I'm going ahead and doing complete phacoemulsification. The nucleus is completely removed, and you can see that now I'm disengaging the loop to make sure the CCC, which is entrapped, is dislodged, and then I'm just holding on to the iris. You can see now the CCC margin quite well. So sometimes this can happen. So if we have a CCC and we have to put in a ring, it's wise to make sure that we disengage the margin of the CCC. This is coaxial IA. Once that is done, I was thinking that the bag was not very strong, so I decided to go ahead. So we have the ring in place to put an endocapsular ring, and that will give more stability to the bag. Once that is done, go ahead and put an IOL in the bag and then remove the Malugan ring. So once I remove the Malugan ring, you will realize that how the pupil actually comes down. So if we have an intra-op meiosis, it's good to go back to these tools, which really aid in our surgery for better results and better outcomes for our patients. So you can see that the pupil has actually come down. This patient was on medication for prostate, and that's the reason why this was expected. But although this is another way I like to make sure that there's no viscoelastic around, just use a Bessett's Y in the other hand, and then go ahead and do coaxial IA, remove all the viscoelastic from in front of the IOL and the viscoelastic from behind the IOL. And this gives excellent results, and this results in good outcome for our patients. Thank you.
Thank you so much, Kumar, again for showing wonderful videos like always. If there are any comments, Dr. K.K. Mehta, sir, would you want to comment on it, or we move on to the next talk? The next
It's a great talk. Perhaps if we had applied hooks a little earlier, life would have been easier, but then we would have missed such a wonderful video.
Yeah.
Thank you.
His experience is what really counts. And I must congratulate you, Kumar, on handling a really rough case well.
Thank you, sir.
So now it is my pleasure to invite the doyen of Indian ophthalmology, teacher of teachers, mentor of mentors, who's taught all of us for last so many years. And he's none other than Dr. K.K. Mehta. He's going to be talking about, again, a very difficult situation, cracking rock hard cataract, the MyLoop way. Sir.
Thank you very much, Namrita. It's wonderful that you invited me. I always love to be with the Aios. Let me share my screen. Is my full screen visible now?
Sir, it is in the presenter mode. I think you have to swap displays. To click swap displays, which is the third icon on the left side.
Third icon on the left side. 1, 2, stop.
It says end show tips, swap displays. Or you can click these 3 dots which are coming in the down left side.
Okay.
So I think you go on the left top. Yes, left top, yes, swap displays. Yeah, the third one first, second, third. Yes, yes, click this.
Yes, perfect.
That's fine?
Yeah.
Excellent. I'm going to go back to the olden days when we had cataracts and we used to utilize loops. In those days, we tried using loops, invariably we tore capsules. We tried using a triple loop, it invariably caused problems. The question was, Recently, I had come across a little toy which was started by Zeiss. I have no relation with them whatsoever as far as this toy is concerned. As a matter of fact, they refused to even give me one free unit. And I just thought maybe it would be something which you could look into. Now, when we have a super hard cataract, our problem is we use excessive phaco time or we do a small incision cataract surgery. But with a hard cataract, you start tugging on it, invariably it leads to a delayed corneal failure. And super hard cataracts are usually accompanied with virtually, as one would say, zero cortical buffering material. So there's always a certain element of chance of damage occurring. Rather than preventing that, we thought we'd utilize a little toy known as a MyLoop. Essentially, it is a loop. But the important thing in this loop, which differentiates it from all other loops, is the fact that when it opens in the shape of a human lens. Then we go a little further on this. It's basically when it opens up, it opens to 10 by 6 millimeters. When you see it in the eye, it literally matches it. And it is made from nitinol. It's got an elastic property, a high tensile strength. I've used it in more than 140 odd cases. I've never been able to break it yet. So it reduces energy tremendously, reduces the amount of fluid you need to use, allows the nuclear disassembly. And the beauty is that the force is directed inwards. Hence, there's never any stress on the zonule. So even in a very hard cataract, you're not worried about it. And endothelial cell loss is naturally significantly less because you cut it into two parts. The edge of the lens comes out, and that's the end of it. But let us see it in action. I'm going to first show you a baby cataract to give you an idea as to how to use it, because most people seem to have not used it at all. When I first started using it, I thought everybody must be using it, but to my surprise, I discovered people did not. Now, the important thing, I'm going to take you steps down the line, so those who haven't used it can have a chance. You must have a capsule excess of at least 5 millimeters in size. You can do it with the smaller one, but it's not recommended. When you open the loop, press the edge of the loop downwards and simply open it. It will open in its own way, but the secret is that you have to press it in this manner so that it stays inwards. You open the loop, you can see the edge of the loop passing. Let it cross the midpoint, very important. Take it back, then support it, the lens, and then simply cut it into two pieces. When you cut it into two pieces, you rotate the MyLoop so that it swings out. Big advantage of rotating it is that it also lifts the edge of the lens out. When it lifts the edge of the lens out, it makes it very simple to do it. You can notice the sharp cut edges of the lens here, which is literally something which is worth seeing, because now we know you've got two beautifully shaped edges. And then removing the edges of the nucleus, getting each of the edge of the nucleus out, utilizing energy is very simple. So it's really a very simple method. It works like a dream, and it really does not break the capsule. Let's look at using a loop on difficult situations. A wide cataract, you can loop, the loop opens out, goes down easily. It may snag once in a while, as you can see, it's snagging a little. We just rotate it a little, nudge it a little, let it go past the halfway line, bring it back again to the center, place your repositor on top to stabilize the lens, as I am doing, approximate the edges, turn the edge of your loop forwards so the loop swings forwards. Advantage of turning it in this manner is not only does the loop come out smoothly and that you won't snag on the capsule, but that it also lifts the edge of the lens up, enabling your subsequent phacoemulsification to be done easily. Once you've done it, we just have to turn it and take it out. Now, each of these MyLoops can be used regularly. Now, let's use a MyLoop on a grade 4 cataract. Hard cataract, you know you're going to be in trouble. Once you get the edge of the nexus, do a little hydrodissection and then swing your loop around. When you know it's a hard cataract, you will have difficulty seeing the edge of hazily, you can see the edge of the loop, indicating the density of the lens. Swing past halfway, put your repositor on the surface, stabilize the lens, approximate the edges. Approximate the edges, turn your MyLoop, lift the edge of your lens out using the same MyLoop. By lifting it out here, it stabilizes the lens. And then when the loop is removed, This time, now you got a case, you put in hooks. It's a tough case. You're jammed. You're now wondering what to do. Same thing. You can use your loop, swing it around again. If it snags, just juggle it a little the way I'm doing it here. Don't be worried. It does not break capsules. Let it go until it juggles its way past. One of the important things to remember is always do a little hydrodissection first. Is the rock hard, so you have difficulty seeing the posterior plane here, but you can see the edge of the loop here. You swing it past its halfway line, put your repository on the surface, stabilize your lens, and then approximate. Swing your loop out, as you can see over here, and then gradually remove your loop. In a simple mind, again to re-explain, when you take this particular lens, let us take another lens, you open it. When you open it, it will open in the shape of the human lens, which is the beauty about this little device. You turn it around halfway, approximate it, and most important of all, again, place your repository on top. If you don't, the lens bounces up and the edge of the loop tends to hit the cornea. So always remember to stabilize it, or if you feel lazy, just press the loop down a little. Sometimes, let's take a look at it in rock hard cataract now. It's a really hard cataract, hard brown. You know that you're going to have a little problem here and there. Same way, do your excess, minimum 5 millimeters in size, a little fluid on top. You place a little viscoelastic on top to press the lens down a little. Open your loop up. The loop will open in the shape of the lens. Don't be worried about it. You only have to be sure that you insert adequately inside as you see it over here. Turn it around. You will notice it tends to snag a little. Nothing to worry. Just gently juggle it a little until it comes in. And then you can, in case you find it sticks, you can take it out and then put it again. There's really no problem in doing that. So there's nothing to worry about as my loop is concerned. Once in a while, it snags a little, take it out and put it in again. And if you notice, you can, once it crosses the halfway line, then you know that the story is over. We just have to approximate the two edges, and that is all that you need to do. Once you do that, you use the edge of your my loop to lift the edge of the lens out, and that makes life very simple. So irrespective of the density of the lens, even if it is a black cataract, it cuts it through just as easily. It's a very simple little device, and which makes life very simple. So no longer are we worried about a hard cataract. What will we do? How will we manage? We just simply, as one would say, eliminate it. Thank you for your attention.
Thank you, sir, for those wonderful demonstration of how my loop can be used and how it helps in all sort of situations. Thank you very much. With this, we move on to the next talk, and the next talk is going to be by Dr. Rohit Om Prakash, who is going to be talking about differential IOP, a new paradigm in phacoemulsification.
Can you see the screen and can you hear me?
Yeah.
Yes, we can.
Yeah, so I would be talking about something else, because I was seeing the videos of previous surgeons, and I feel that I'm feeling out of sorts here because I would be showcasing a different viewpoint about different things. Differential IOP, a new paradigm in phacoemulsification. This is what my talk is. We know high IOP or a bottle height uses high fluidics, and it gives us a big advantage of non-fluctuating anterior chamber, deep anterior chamber, as you can see. Now, we should know what are the disadvantages of using this high IOP during phacoemulsification. We can have a wipeout syndrome in advanced glaucoma patients. The procedure is painful at times, more so in those patients who have a higher baseline IOP, where the anterior chamber depth is larger and the axial length is larger. And then there's a lens iris diaphragm retropulsion syndrome, which is more often seen in myopes and vitrectomized eyes. In these patients with high IOP phacoemulsification, there is compromised anterior segment wherein we have increased Decimet's folds, more anterior segment inflammation, more edematous corneas, difficulty in short eyes, giving stress to the zonules. And it has been seen in some studies that there's an anterior vitreous phase rupture, even with an intact posterior capsule. So what I'm going to showcase, what is the answer at times is that we use low IOP phacoemulsification, wherein, the fluidics decreases, there is less deepening of chamber, the nucleus fragment floats, and the flow rate is relatively changed accordingly to have stable chamber settings. So this low IOP phacoemulsification, other than the fact it takes care of the disadvantages of high IOP phacoemulsification, it causes low turbulence. Because of which there is decreased mechanical trauma to the corneal endothelium. There is better retention of OVD, which causes more protection to the endothelium. The downside is also there, and that downside is that there is a less anterior chamber and back depth, because of which that there's a less working space in emulsifying hard cataracts, wherein there is a high lens thickness and lesser anterior chamber depth. So in these patients, we have more of endothelial trauma, so which has to be borne in mind if we use low IOP. So I divide this emulsification process in my practice into 3 categories. First is the physiological IOP, wherein I do phacoemulsification between 18 millimeters of mercury to 22 millimeters, supraphysiological IOP between 23 to 34, and sub-high IOP between 35 millimeters mercury to 45. This 45 boils down to 60 centimeters bottle height. So let's see, different applications. This is a patient who had an advanced glaucoma. So the first thing which I'm going to do is I'm going to create a calibrated sight potency to give me additional, stability. The IOP is 20. The aspiration flow rate is 23. And you will find that despite using such low fluidics, wherein I'm having stable chamber settings, you will find that the chamber is not fluctuating. The iris, the pupillary margin is not fluttering. This shows that the chamber is stable, and there is no chance whatsoever of the patient having any, wipeout syndrome in these patients, wherein the advanced glaucoma is there. Last but not the least is that you keep the pressure on the lower side, and you can very well ascertain with the intraoperative OCT that the chamber is sealed. This is another patient wherein there is a pre-existing defect. The same parameters of 22 millimeters mercury are being used. This was a softer cataract and not that hard, which I had anticipated. You will find that there is no undue deepening. The chamber is absolutely stable. There is low inflation, because of which there is no hydration of vitreous, and the nucleus is floating. So this is mechanical, dissociation of the nuclear fragments. And now stable chamber settings with settings of low IOP of physiological of 20 millimeters, of mercury, visco separation. And after visco separation, you will find how I'm trying to, everything is being done in slow motion phacoemulsification. At the end of the surgery, you will realize that the size of the posterior capsular defect is the same as it was before and after surgery. This is another case wherein, the resident, the same physiological IOP or supraphysiological is being used. You could see the punch. Here I'm using 28. I could have used 20 also. Another important thing which you have to bear in mind is that in this patient, hydrodissection has already been done. So I would not be having any problem whatsoever in taking out the divided nuclear fragments with low IOP, low fluidics, in the sense that the flow rate is on the lesser side, slow motion phacoemulsification, there is less infusion, no pushing back of the nuclear fragments, stable chamber settings. And what you will find that at the end of the surgery, what we have resulted in stable chamber settings, the dry aspiration being done, and you will find that the size of the posterior capsular rent is same. So this is what low IOP does in a posterior capsular punch. This is another video. We are talking of retropulsion iris, a lens iris syndrome, diaphragm syndrome. This is a patient who is a high myope. So you can use physiological IOP or a supraphysiological IOP. Mark my words, the problems which you have with high myopes and with vitrectomized eyes, they go into oblivion because there is no undue pushing back of the, of the lens iris and the deepening of the anterior chamber, subsequent to which you will find that it appears as if the surgery has gone in the routine way. This is with the physiological IOP or supraphysiological IOP in a patient who is on tamsulosin. The IOP which I'm going to use is this is the adrenaline or the epinephrine which is being used. Since the receptors had not been atrophied, so there is some bit of dilatation. No, you could use Arshanov's technique of visco usage also. Calibrated side port incision is being used. Hydrodissection is being done minimally, no aggressive hydrodissection. Then the next step is, irrigation off, go in. Once you go in, I'm using IOP of 20 with aspiration flow rate of 23. So I'm not attracting the iris. With the low fluidics, there is less access of fluid to the posterior aspect of the iris, subsequent to which there is minimum amount of the movement of the iris. You can find that the size of there was no fluttering. Irrigation off, I came on. Irrigation off, then you put on irrigation on, and you can find that the size of the pupil is the same as it was there in the beginning. This is a rock hard black cataract. Here, what I'm going to use is, I'm going to use a differential phaco also. I'm going to use supraphysiological IOP and a sub-high IOP in Brunnesen cataract, which has increased thickness and low ACD. Now you will see what I'm going to do is, so this is the anterior chamber depth is increased in these patients. I start with the supraphysiological IOP of 32. I'm going to do a, sculpt, create a small crater, and then I'm using the chopping, wherein there is only longitudinal phaco. Here, the IOP has been increased to 42, and the flow rate has also been increased to have a better grip on the nuclear fragment. Here, total separation of the nuclear pieces has been done. Viscoelastic is being re-injected, viscoed for that matter. I'm using, chopper shield here. I need maneuverability. Had the IOP been on the lower side, there would have been less space for me to work on it. I don't use MyLoop in hard cataracts because in hard cataracts, I want 6 or 8 pieces, which are not possible by any means when we use MyLoop. So MyLoop in my is possible only in softer cataracts, quite contrary to what has been used. Other applications include generalized zonular weakness, subluxated cataract, and patients who feel pain. So, differential IOP phacoemulsification involves horses for courses. It's a paradigm of different low IOPs, wherein different IOP is used in different situations, in different steps to maximize patient outcomes. Thank you very much for giving me the opportunity.
Thank you so much, Dr. Rohit Omprakash. I think another new concept, you have given a new definition, a new paradigm to the way we should do our cases, and especially where we should use, and given so many new terms, the physiological IOP, the supraphysiological IOP, and the subphysiological IOP. And I think this probably none of us or nobody actually thought about it, that in the same case, you could use different or varying IOPs. I'm sure this concept is going to go a great way. And thank you for showing those beautiful videos and that very useful concept. Any comments? Priya, would you want to say something? Or Sonu?
I just wanted to understand your concept of calibrated side ports.
Absolutely. Calibrated side port, we are giving a step sun treatment to the side port. We are doing calibrating the main port. We are not calibrating the side port incision. Whenever there is a non-calibration of side port incision, when I say calibrated, what I mean is my side port instrument is a 25 gauge needle, which is a 500 micron, which has a diameter. The instrument, the chopper which I'm using, is 400 to 450 microns. 400 micron at the distal end, 450 micron at the proximal end. Subsequent to which there is no undue efflux of fluid from the side port incision. So this no undue efflux from the side port incision is creating a situation wherein there is a stable chamber setting. I have been seeing videos across the world in instruction courses where I have found that surgeons are talking about IFIS, and what is the precipitating cause is, the iris trauma at the side port, which is creating a situation where there's a stepwise involvement, and it ends up with a situation that you have a full-blown IFIS. So side port incision calibration is the most overlooked part in our phacoemulsification. So calibration helps a long way in taking care of so many things which we never felt happened.
I think it's a very beautiful concept, Dr. Rohit, you have come out with. We all knew that, in certain cases, we can go with low parameters and everything, but you have categorized everything so nicely that, things have become very clear. So I think that's very nice.
Thank you so much. I think we'll go to the next talk. I don't see Dr. Arup Chakravarti. So we'll go to, it is my pleasure to invite a very fine and a very elegant surgeon, Dr. Sonu Goyal, and he is going to be talking about 1 lenticule in 8 seconds, world's fastest femtosecond laser.
Thank you, Dr. Namrata Sharma, ma'am, for that wonderful invite. And yeah. So am I audible and visible?
Yeah, perfect.
So thank you so very much. Faster is better. So another 8 minutes, I'll take you through the journey of this wonderful toy, which is called the VisuMax 800. So we all know the basic key steps in smile surgery. Basically involves the creation of this lenticle cut. You have this next step as the lenticle side cut, then you have the cap cut, and you have the cap side cut, which finishes off in 28 seconds on the VisuMax 500 platform. There have been categorical advantages with the lenticle extraction, with the smile surgery. It's highly predictable, gives you a very refractive, stable platform. The recovery is very fast. There is little or no intraoperative and postoperative pain. And definitely with the Circle software, the enhancements can be done. But there have been certain unmet needs. There has been a risk of suction loss because the duration is usually 26 to almost 32 seconds. The centration has been a real big bug. We are not able to manage hyperopia on this platform. And yes, we have seen all throughout this morning talks on how OCD-guided surgeries can enable us and can refine all these surgeries. And definitely, if this becomes OCD-guided, can be a great boon. And cyclotorsion registration when we are dealing with astigmatism or cylinders on a very high magnitude. So this VisuMax 800 is the latest generation femtosecond laser. The beauty is this 2 megahertz laser source, which actually transforms to a laser time of almost 10 seconds when you're talking on a lenticule extraction, and almost to 5 seconds when we are talking on a flap creation. And believe me, with this 1.2 software making the tissue separation easier, and this basically, if you see here, is the real-time picture. On the left is the 500 platform, on the right is the 800 platform. By the time I complete my surgery on the 800 platform, I've just been able to manage the lenticule side cut. So that's the biggest victory. And believe me, most of these suction losses would occur usually between 10 to 23 or 25 seconds when the patient actually starts losing their patience. So we all know that the suction loss has been the biggest bug. And in the multi-center study done so far, it's almost close to 1.34 seconds. So gone are those days when we actually turn our back, look into those charts, actually where we did the loss or where the section loss occurred and how to manage. This wonderful article, none other than Dr. Tatyal and Dr. Namrata Sharma came up with this learning curve of the smile, which said that the lenticle dissection and the extraction is the most difficult step. But believe me, with the newer software 1.20, which basically transforms the spacing of the lenticle from 4.5 microns to 3 microns and the side cut to almost 1.5 microns, and the energy delivery of 26 into 5 nanojoules, making the dissection so smooth, causing these posterior stromal damage, the anterior capsular tears, the side cut tears, or the chances of retained lenticle almost negligible in the practice. Another great feature of this equipment is the central line. If you see here, this actually would help in aligning the right on the visual axis. So the offset from the pupil center can be calculated out using the atlas, and it's the time when these the equipments would be talking to each other. A quick video is shows how to the world of VisuMax 800. Smile Pro on VisuMax 800. This is how the patient is taken, painted drape, and proper fornix saline is cleared. So this is how the side view, you see the operating microscope, the arm has been scrolled down, and this is how the arm goes up. And this is the laser microscope, which moves down on a click of a button. And very wonderful workflow, easy system. And the joystick is then rotated, and this is the laser component which comes down, if you see on the video. And this is the point where the treatment pack has to be connected. So the one end of the treatment pack goes here, and the contact glass is then supported and gets self-illuminated. And then you slowly dock. And this is the beautiful centration device on this, which connects onto the visual axis. This is how you center, and the patient is always looking into the green light, and it guides you to have the right centration of the visual axis so that the treatment always remains onto the visual axis the moment 90% of docking achieved. And this is how the spiral in and the spiral out. 8 seconds is the total treatment taken, and it's just the blink of an eye. So amazing. So gone are those days of the suction loss, and a good treatment can be achieved on this. This is how the final picture looks, opening of the main incision, and just watch very carefully how smooth the dissection plane is. This is once with the 1.2 software and the change in the spot spacing from 4.5 to now 3 microns is the spot spacing for the lenticule, and 1.5 for the side cuts. And with the energy levels of 26 into 5 nanojoules, beautiful free-floating lenticules can be achieved. And this is how, with the hydro expression, the lenticle can be expressed out. And beautiful refractive outcomes with this VisuMax 800 systems can be achieved. This is the day 1 post-op picture, absolutely crystal clear cornea, and hardly any incisions which can be made out. So thank you so very much. So a newer addition is the cyclotorsion alignment, and shortly this would be talking to our IL Master 700 and the Atlas with the what is called as the Forum software. And this is how actually it transforms. You see here, once you have done the docking, you can actually rotate and align to the desired axis. So I think all in all, this system is basically aimed at to give better refractive results, quite predictable. The patient is quite comfortable because actually the suction time has gone down, and it has really made our workflow very easy, and definitely has transformed into less surgical and OPD man hours, and definitely those peaceful nights. So thank you very much for making me part of this program and the August gathering. Thank you so much.
Thank you, Sonu. Thank you for showing us yet new frontiers in the SMILE platform, and I'm sure there would be more and more innovations, and that was really quick and fast dissection. I would now request Dr. Sujata Mohan to talk about dislocated intraocular lens management.
I'm just. Where do I share? I'm not able to get that. Where is the share?
It's at the bottom in the center, green
Yeah,
button.
it's sorry about that. Yes, I'm starting. Thank you, Namrata. At the outset, I'd like to thank Namrata for giving me this wonderful opportunity and to share the platform with such amazing surgeons. So I've slightly changed my topic so that I don't overlap whatever Mohan has spoken, and I'm going to speak to you on dislocated IOLs fixation techniques. Are you able to hear me, Namrata?
Yeah.
Right.
Yeah,
So I'm going to show you a series of cases that we faced. This is a case who had a 70-year-old male who had a phaco-foldable done by us about 15 years back, and he complained of oscillopsia, meaning that shaky vision. And so when we looked at him, we could see that as a patient is moving his eyes, the entire IOL back complex was moving. And this was a multi-piece IOL. So the decision was made to do a glued IOL. And so the eye was being prepared for a glued IOL. So as you can see, flaps are made, a posterior infusion line is being created. And through the side port, so Chariot's pockets are created on either side. Again, sclerotomy has been done. And you can see through the side port, the IOL is being lifted and it's brought on top of the iris. You can see almost non-existent zonules in this patient. And I tried to remove the capsular bag using a cystitome, but unfortunately it was difficult. So I used a vitrector to actually remove the posterior capsule. There was no vitreous actually in this case. And as much as possible, I tried to free the lens from outside the bag. And then using a handshake technique, I'm catching on to the haptic and retrieving it through the sclerotomy, which has been created under the flap. One haptic has come out while I'm holding on to the other haptic with a Y fork. And now again, the same handshake technique, and the other haptic is also being retrieved. And the Chariot's pockets have already been created. And so the IOL is tucked into these haptics, are tucked into the Chariot's pockets. And a minimal anterior vitrectomy is done to remove the capsular bag, a little bit of the capsular bag which is present, and also to check just to make sure that there is no vitreous present. So the entire case went very smoothly and uneventfully. And post-operatively, the patient had a very good outcome. As you can see in this case, when the patient is moving his eyes, there's absolutely no movement of the lens. And he got back a 6/6 vision without the movement of the vision. So this second case was also a very similar case. A patient had complained of worsening of vision over a 2 months period. And this, you can see this is a single piece IOL, and you can see the haptic optic junction in the pupillary area and also the movement of the IOL. So we decided a different technique for this and decided to go ahead with the Hoffman's pockets. Hoffman's pockets are small pockets which are created starting from the cornea into the sclera for about 3 to 4 millimeters. The basic idea is to use the pocket to bury the suture. So once when the pockets have been created, through the top of the pocket, you can introduce a 26 gauge needle, and through which the 10-0 polypropylene is railroaded. So one loop goes on top, and the other similar loop, which is made using the 26 gauge needle, is again goes from the bottom of the haptic. So basically the haptic, the 10-0 polypropylene is looped around the haptic of the IOL. You can see as the needle is pulled out, you can see that the lens being pulled towards one side. So then after that, you retrieve the suture from under the pocket and keep it aside. This is just to prevent you from getting confused with the second set of sutures. Then again, you do the same thing on this side. And you can see very clearly how the 26 gauge needle is going under the haptic and the 10-0 polypropylene is railroaded into it. And this is pulled out. So the next one goes on top. The only thing is to remember to prevent talking of the lens, you do the exact opposite on either side. So first loop goes on top, the other one goes at the bottom. So now you've retrieved on both sides, you've retrieved both the sutures. Just make sure that the IOL is in the center and then tighten it gently so that you don't over tighten it and then pull the IOL towards one side. It's very important. Just make sure that IOL well centered. And you can, if you want, you can remove the capsular remnants. Otherwise, you can just leave it alone. So this patient also had a very little disturbance, and we did use a tricot to check for any vitreous loss, and did a minimal anterior vitrectomy. The third case is a patient who had multiple times dislocated IOL done elsewhere, and this time he wanted the final word. Fortunately, this time he had, this was again a multi-piece IOL. That is the advantage when you have a multi-piece IOL. You can always plan a glued IOL very easily using the same IOL. Only thing you have to take care that you don't drop the lens inside, because there's absolutely no support, posterior capsular support. A minimal anterior vitrectomy is being done, and the haptic is retrieved from under the sclerotomy and brought out. The similar thing is being done on this side. So all these cases will definitely need an infusion line, either a posterior or an anterior infusion to maintain the anterior chamber. And you can see this is all ab interno. I've not even opened the eye, and that is a great advantage because the earlier and quicker recovery also matters in these patients. So once that is done, this patient did extremely well. The last case I'm going to show you is a patient who had a dislocated IOL. And again, this is a single piece PMMA, single piece hydrophobic lens. And so again, this patient, I had a doubt whether it would be possible to do a fixation. So I decided to plan for a glued IOL. But nevertheless, I thought, let me try using a Gore-Tex suture instead of a polypropylene. And the technique is almost similar to what I showed earlier, using the Hoffman's pockets, but only thing now we are going through the sclera under the flap. So again, an infusion line has been placed, and the Gore-Tex suture is retrieved from under the flap, and one loop goes on top while the other loop goes from the bottom. So you can see that through the sclerotomy, again, the second loop is being pulled out, and it is looped around the haptic. So the same thing is being done on the other side, but this time the first suture goes on top, so that prevents the torquing of the IOL. And now you've got a very nice, on both sides, you can see that it's like swinging like a hammock. And again, tightening the suture and making a knot, you have to be very careful that you don't over tighten on one side. Just keep it a little bit loose. You can always rotate the Gore-Tex suture inside, or use something like because I already created a flap. I buried it under the flap because it's notoriously, it can come out and it can cause endophthalmitis and other problems. So I'm checking to see if there is any vitreous. I'm doing an anterior vitrectomy to remove all the capsular bag, and also there is, you can see some Elschnick's pearl which is floating out. So that also needs to be removed. So almost all the bag along with the Elschnick's pearl is removed, and I'm just checking, just making sure that the IOL is placed in the center, and then tightening and trimming the sutures and putting some glue and sealing it. So the case ended very nicely, and the patient regained excellent vision. So these are different methods of handling dislocated IOLs, and I would like to thank Dr. Namrata for giving me this opportunity. Thank you.
Thank you, Sujata. Those were really wonderful situations and wonderful cases and sets of videos which covered everything that is possible as far as the dislocated IOLs are concerned. Thank you very much. It is now my pleasure to invite my very good friend, Dr. Priya Narang, who's changed the way we look at the iris completely. And she is going to be talking to us in advances in iris repair. We thought about cornea, we thought about lens, but that iris exists also. Priya has changed the way we look at it. So over to you, Priya.
At the outset, I would like to thank Dr. Namrata for inviting me to this wonderful webinar. Thank you so much. I hope my screen is visible.
Yes, everything is fine.
Perfect. Thank you. So, well, I will be covering up the advances in iris repair, and sparing a lot of time, I will just switch over to a newer technique for doing a pupilloplasty procedure, that is the reverse fourth-row pupilloplasty procedure. Basically, I differentiate iris repair into the base repair, that's the iridodialysis repair, and the pupil-centric method. So this is a newer pupil-centric method, and we all are well versed with single-pass fourth-row pupilloplasty. So today, I present here the reverse fourth-row pupilloplasty procedure. So basically, in all techniques of pupilloplasty, we always have sutures on the anterior surface of the iris. But with reverse fourth-row pupilloplasty procedure, we have the knot coming up onto the posterior surface of the iris. So that's the beauty of this surgical technique. So this is the clinical video. Here you see that, there is the withdrawn pupil on one side. So I decide to do a pupilloplasty on this side. So what you see here is the Tano needle. It pierces the proximal aspect from the posterior surface, emerges on the anterior surface of the iris. And then again, I have the 26 gauge needle. It again pierces the distal part from the posterior to the anterior surface. And then we railroad this the suture needle into the barrel of the 26 or a 27 gauge needle, and then we withdraw this. So the way we enter the iris tissue makes all the difference for this kind of pupilloplasty procedure. The rest of the procedures for all of the people who are doing a single pass remains the same, that you withdraw the suture loop outside, and then the end of the suture passes through the loop 4 times. You just take 4 throws and you are done. And this is what we had described. This is a self-sealing and a self-locking knot that forms just like we do for the single pass fourth-row pupilloplasty procedure. And then for this RFT, you just cut the suture ends. This is the suture track that forms in the reverse fourth-row pupilloplasty procedure. The entire suture comes from above the surface of the iris, and you get the knot behind. I also call it as an iris stapling because it really looks like you have stapled the iris, and I'll be showing you the post-op photographs of these cases. This is another video of the reverse fourth-row pupilloplasty procedure. Again, most of the times, whenever we do the secondary IOL procedures, many times we get updrawn pupil, and there's always the possibility of having an optic capture. So these are the cases where we actually end up doing pupilloplasty in one of the portions. The concept being that, the size of the pupil should be a little less than the diameter of the optic to prevent an optic capture. So again, what you saw was, the needle from both the sides entering the iris tissue from the posterior surface and emerging on the anterior surface of the iris tissue. You withdraw the loop, take the 4 ropes, pull both the suture ends. The knot, it very nicely slides inside the eye, with the difference that it slides onto the posterior surface of the iris tissue. So now, technically, what I would like to say is that in most of the cases where we do pupilloplasty procedure, we try to center the pupil first in the center and then go and seal all the peripheral defects. But with RFT, we need to seal the peripheral defects first and then come to the center. So everything goes reverse with this kind of pupilloplasty procedure, which is soon going to be published in one of the peer journals. You can have a look at these post-operative images. You do not see any suture knot or the suture tail or the suture stubble inside the anterior chamber. Everything goes behind. And, the beauty is that in many of the cases, you cannot even identify that you have done a pupilloplasty procedure because there's nothing to be seen except the surgeon knows that he or she has done this procedure. Even anterior segmentosity does not denote anything in the anterior chamber. So this is how it actually looks like. So this is just my small presentation, which I just wanted to make, taking this opportunity. Thank you so much.
Thank you, Priya. Lovely presentation and another new concept, I'm sure, which is here to stay, and the new way of repairing iris procedure. I always used to think why even when we were doing open sky penetrating keratoplasty, why we are, putting the knots anteriorly. And I think it is going to be very useful for endothelial keratoplasties because you have a graft which is going to be sitting there and the knot is not going to be rubbing or touching against the graft. So
Absolutely.
I hope to try this in those cases. Thank you so much, Priya, for again bringing in a new concept. Thank you.
Thank you so much.
Thank you. It is my pleasure to now again ask a very good friend, Dr. Purinder Bhasin, to present on managing capsular fibrosis during phacoemulsification.
Am I audible?
Yeah.
At the outset, I would like to thank Dr. Namrata Sharma for giving me this opportunity to be in this wonderful webinar. All the talks are so beautiful and so captivating and innovating. I will be speaking on managing capsular fibrosis during phacoemulsification. I don't have any financial interest. Can you see my slides?
Yes, yes.
Okay, so capsule fibrosis could be on over the anterior capsule or the posterior capsule, and they are commonly seen in cataracts like a traumatic cataract or a complicated or in cases of uveitic cataract, and in congenital cataract cases, and in long-standing hypermature cataract cases who have not been managed earlier for the surgery, and in post-silicone oil-filled eye. We all know the anterior capsule is thick in the center and in the equatorial region, and the posterior capsule is 1/5 of the anterior capsule in thickness. So we have to be very, very careful in managing and handling these cases. In this particular case, there is a thick anterior capsule fibrosis. So it was very difficult to make an initial puncture. And there, in this particular case, we make a multi-point capsular cutting with the help of the curved micro scissors. And we have to make incisions at multiple places from where our micro scissors and micro instruments can enter. And this is how a circular opening is created, and a phacoemulsification of a soft lens is done, and an IOL implantation is done. And after the IOL implantation, this is how it looks. Another case wherein this is a long-standing hypermature cataract, and the capsule is fibrosed over this region. And after making an initial cut with the Vinus scissor, a central fibrosed capsule is encompassed and around the central fibrosed area, and a continuous curvilinear capsular axis is completed with the help of a forceps. And then the hard cataract is emulsified in a usual way. The initial cut in the capsular axis should be such that there is no the angulated area which can go to the periphery, and extension of the peripheral extension of the capsular axis to the posterior capsule occurs during the phacoemulsification of this procedure. And rest of the thing is done in a usual way. Another case, uveitic cataract, you can see there is a posterior synechia, and in that region, the capsule is also fibrosed, and a liquefied cortex is present. After absorbing the liquefied cortex and making initial cut with the micro scissor, which is a curved micro scissor, we make we cut the fibrous capsule. Otherwise, if you are going to pull it, you are going to create a stress on the zonules, and we can have a zonal dialysis, and you can never do a successful phacoemulsification. In majority of these cases, you see the cataract is a softer cataract or a liquefied cataract. In this particular case, there was a posterior capsular fibrosis also. And I will be showing my technique of managing posterior capsular fibrosis. And here we are doing a posterior capsular axis in order to give a good quality vision in the immediate postoperative period, which all these patients do expect. And this was pediatric cataract. I didn't want to take him for a resurgery and exposed to the general anesthesia. That's why I did a posterior capsulotomy also, and we always do in congenital cataract, and pediatric congenital cataract, we always do posterior capsular axis. This is a complicated cataract case with the small pupil And you can see that in the area of exposure of the toxins or proteins released in the anterior chamber, the anterior capsule gets fibrosed and opacified. And I'm trying to see the intensity or the thickness of the capsule with the help of the cystotome. And it was very, very thick capsule and very difficult and not very easily cut with the help of the micro scissors. But we could manage it with the difficulty, and it is cut at multiple places. And here I am using a Vanna scissor because micro scissors were which gives a less force or cutting force than the Vanna scissor, which is sturdy. And after making a central opening, cutting a central opening, we are aspirating the cortex or lens matter is aspirated. And here also we see that there is a posterior capsular fibrosis too. Another case with a long-standing hard cataract. Here we are trying to see the extent of fibrosis and if there is any place where we can make a initial cut or initial opening to which is done, and after that a scissor is passed through that opening. And I'm trying multiple ways so that if we can get a circular capsular axis in this particular case, because it's a hard cataract, and I will be happy if we get a circular capsular axis, kind of a strong opening in the anterior capsule so that it should not extend to the periphery, but it was difficult. So we then cut it and with the scissor in this region, and an extra opening is made in at inferior part or over the rest. Usually we make two side port entries, paracentesis entries. Here we have to make one more side port entry, and then we can go from 4 sides and make a circular opening. Otherwise it becomes very, very difficult. And this phacoemulsification is done. Now coming to the posterior capsular plaques. So these are commonly seen in cases of complicated cataract or a cataract with the electrocution or trauma. So in this particular case, after doing the phacoemulsification, we see that there is a thick central large plaque, and it was just like leaving behind the cataract, and the patient would have not recovered any vision, gained any vision even after the cataract surgery. So what we did, we just lifted the edge of the plaque, and this ledge is created, and with the help of utrata forceps, I'm just peeling it off. And if you find it difficult, you can use a second instrument and dissect it, and this comes out in totality as a whole like a chapati, or it comes out, and this plaque can be removed easily. And you don't have to do posterior capsular axis, and your posterior capsule is intact. This is again a complicated cataract case wherein the posterior capsular plaque is also there, and I'm doing a axis there. And after this, the posterior capsular plaque is now peeled with the help of same micro forceps. Just lift the ledge of it and then pull it out. This plaque is quite thick, and then the cortex is removed, and there is a posterior capsular fibrosis also along with this. Now we have created an opening in the posterior capsule too. This plaque is removed. Anterior chamber is filled with viscoelastic, and with the help of scissor, if you try to pull these plaques, because our posterior capsule is of 4 to 5 micron thickness only, then it is going to, the capsular axis can extend to the periphery. There is adhesion of the vitreous to this plaque in the posterior capsule. So we have to cut it, maybe with the help of Vanna scissor or maybe with the help of retractor, and lens is placed in the bag. Both our anterior and posterior capsular axes are intact, and the lens is placed in the bag. This is another case wherein the fibrous plaque is seen, which is not a thick or a wide or a broad one. But this also is going to decrease the initial quality of vision, and more so in our premium multifocal or the EDOF lenses cases. So this plaque comes, which is almost circular, and in the region of the pupil, nearly 3 to 4 millimeter in size. So definitely this is going to hinder the vision in the post-operative period, and early capsulotomy can be avoided if we do it, manage it during the and a vacuum cleaning of the posterior capsule is done after this, and a lens is implanted. So in multifocal cataract cases, if you find such posterior capsular opacification, it's better that we peel them off, and after doing it, if they are not able to come out, then we should manage it by doing a primary posterior capsular access, as you can see here. So variety of, and then we can implant the multifocal IOL in such cases, which is very, very important. Even if the slightest amounts of posterior capsular opacification is there, then it is going to round circular capsular access is there. So last, when we see the partially absorbed lens, so in such cases, the anterior posterior capsule and the lens matter is completely the fibrosed, and altogether it's like a sandwich, and wherein the lens matter anterior posterior capsule is one, and I'm trying to do make any opening with the cystitome, but I'm not able to get. It's like a smooth, dense, hard surface. So with the help of Vanna scissor, I have made a radial cuts in the posterior, this partially absorbed lens, and these cuts are now, and this is very thick and very hard, and not easily amenable to cut or remove by the vitractor also. So then we can enlarge it with the help of a vitreous cutter, and then a lens is placed in the sulcus. So this is how we have enlarged it with the help of cutter, and we make a large wide opening. And this was a case of the developmental cataract. This was in the 12 years old child. This patient had this kind of long-standing cataract. So take-home message is, for the fibrous plaques on posterior capsule, fill the anterior chamber by OVD and make the PC flat. Lift the posterior capsule fibrous plaques with the help of cystitome, or you can use a Sinskey hook to avoid any hole or tear in the posterior capsule, and peel the fibrous plaque using the Utrata forceps. In case of thick fibrous anterior capsule, one should use a curved micro scissors to cut capsule and in a circular fashion, and this helps in making a circular opening. Phacoemulsification by cutting anterior capsule is useful in a softer cataracts or a liquefied cataracts, and in hard cataracts, there is definitely a risk of extension to the periphery. I thank you for your patient hearing.
So thank you, Dr. Purendra Basin, for I think the entire encyclopedia of how fibrosis can be managed. I think this was a useful collection of cases, and all possible situations were covered. I would now request Dr. Satyajit Sinha to give his talk on management of traumatic cataract in the next 8 minutes. I think Dr. Lane sir and Dr. Ragini have also joined. I think it is through.
Yes, Namrata, we have joined.
Yeah, yes, sir. Yes, sir. I guessed that it is in that. Okay, sir.
We are in Yavatmal doing the camp.
Yeah, I guess, sir. I guess, sir.
Very good morning to everybody. I'd like to thank Dr. Namrata Sharma for giving me this opportunity to speak on management of post.
Satyajit, we can't hear you.
I'll be speaking on management of post-traumatic.
I think there is some problem. There is some problem with the connection, Satyajit.
Namrata ma'am, can you hear me?
No, the voice is cracking in between.
Can you hear me?
Yeah, now it is clear.
Am I audible?
Yeah, you're audible now. You're audible. You're audible. Satyajit?
Can you hear me, ma'am, now?
Yeah, we can hear you, Satyajit. Please carry on. I think now he's gone. I think I would then request Dr. Lahane sir to please give his talk. Dr. Lahane, of course, needs absolutely no introduction. Doyen of Indian ophthalmology, who's brought out so many reforms as far as the ophthalmologists are concerned, not only in Maharashtra, but also nationally. Sir?
Yes, Namrata. I am a brother of Namrata. I'm not dying on anything. So I'm in Yavatmal, and so I'm presenting this presentation from Mad Securities computer. Now I will just
Yes, sir.
Namrata, can you see my this one?
Yes, very
presentation?
nice. Yes.
Okay, thank you, Namrata, because we are in very interior. So as you know, there is no any financial interest. I'm going to present my, as I'm in the interior area, I'm going to present my cases which are there on my, can say the mobile, interesting cases in the FECO. So this is for the, can say the learners, that is the residents. This is a mature cataract, and you can see here I'm doing the rexis, and this is a after staining with this, I'm doing the rexis, and this rexis you can see, and after the rexis, here I want to show you something that is a, I'm doing the chopping, and you can see the both, that is the chopper and the tip. You can see the both chopper and tip are in the same line, and I'm just doing the chopping here. You can see the chop, and see the chop is completed here. Again, I'm doing the chopping. See, always remember, whenever we are doing the chopping, it should come from the periphery to center, and it should separate the pieces. Now, as this is, though it is a mature cataract, but it is very soft cataract. So it is not like an hard cataract. So whenever we are removing this type of nucleus, it is always better. You can see I'm going so slow. FECO is not a, you can say, fast procedure. FECO is the procedure which can give the better results and good results. So you can see now I'm going very slow so that I can complete the my FECO emulsification. So the second case now I want to share with you. Now this is the posterior synechia. And if I am operating in the interior, and you can say no hooks and nothing with me. So now see, whenever I'm doing this, because so many cases they come and then they go to one doctor, two doctor, three doctor, and after that they come in the camp, and it is very difficult in such situations. So without the hook, what I do is I just remove all the, you can say, the synechia in 360 degree. You have seen the synechia is removed. Patient is given steroid for the 2 days. Then I am doing the rexis. You can see, though it is stained, it is a stain is not seen because people are very small. And then now I'm doing the rexis because this stain is because of the pigment on the lens. See, now I'm separating the nucleus. You can say hydrodissection, and after that, now I'm doing the FECO emulsification. Now in the FECO, as you know, it's a very small pupil. What I'm doing is you should remain in the center. Once you remain in the center, make the 2 pieces, and after that another 1 piece, and you can chop. So stop and chop technique I always use because chop is not possible here. So in the center, I make a trench, and once it is made the trench, then I make a 2 pieces, and then I will do the chop and another 2 pieces, and then the tip of the, you can see the peko always remain in the center. So tip never goes on any side. So it is in that area of the, you can say 3 millimeter. So in that only I'm just removing the nucleus, and I'm not going on any side, because once you touch the iris, then iris will come in between, and that iris, then it is impossible to do. And then this is my aspiration cannula, by which I aspirate the thing. I'm not using the aspiration, irrigation aspiration of the peko. Then this is my another case. I'm doing this, and after it is a mature cataract. But if you see the lower part, you will see there is a, can you see this is a piece here, because this is a dramatic cataract here, and tear is seen. So what I am doing is the armor. Now in the armor, what I have done is, it is not a 3-piece lens, it is a 1-piece lens, because there is a bag, and I can able to put it in the bag. So I have used the 1-piece lens, and always remember it should be kept on the iris and not in the back. Sometimes it may slip down. And after that, now I am doing the peko emulsification here, and gradually removing this cataract. So whenever you are in difficulty, then you can just think of the armor, and then you will definitely do that. And then I will rotate the lens and put it in the bag. So thank you, Namrata. Thank you very much.
Thank you so much, sir. Thank you for your kind presence. Despite the fact that you were in a camp, you were able to do it. Thank you so much, sir. Thank you.
Now, Ragin, Satyajit, you are there? Satyajit?
I can't hear Satyajit. Are you muted? You are muted, Satyajit.
Yes, sir.
His network is poor.
Yes, sir.
Yes, sir. Start, Satyajit.
Can you hear me?
Yeah.
Satyajit, तेरा आवाज कम आ रहा है. We hear you in between.
I think we can't hear him now.
I think we can go ahead with Ragini.
Okay, sir.
I'll be speaking on management of post-traumatic cataract. And a study performed for the World Health Organization estimated that 55 million eye injuries occur annually worldwide, and up to 1.6 million people lose their eyesight due to eye trauma. Trauma can affect in several ways. It may be there may be subluxated lens, or there may be dislocated lens.
Slides have to move. Yeah, you move the slides, please. Again, the thing is unshared.
I think he's lost my connection, ma'am.
Yes. So, in case Ragini, would you speak? I think Prashant has to catch a flight. Prashant?
Yeah,
Sir,
yes,
whatever
ma'am. I
you
have a
say,
flight
sir.
to catch, but sir is in a camp, I think.
Okay. So Ragini, please speak.
Ragini will speak.
So it is my pleasure to invite the next speaker, who is a true friend, and Dr. Ragini Parekh from Mumbai. And she's going to be speaking on, again, interesting topic, phaco chop techniques.
Thank you so much, Namrata. Good afternoon, everybody. And thank you, Namrata, for inviting us and always making time to call up everybody personally. And congratulations to you for being what you are always. Good afternoon, respected teachers and friends. I will be talking on phaco-chop techniques. Phacoemulsification can be done by various techniques, direct chop, stop and chop, flip, or you can customize it to your own technique by using multiple techniques learned from many surgeons. The important thing is that while doing anything, you have to see to it that you protect the cornea and the ocular structures. So when you have a very, very hard cataract, and now with the Indian lenses becoming cheap, as you can see over here, there was a mature cataract which is stained, the capsule is stained, but inside it, it's a cataracta nigra. This is a direct nigra chop. So the first chop is a direct chop without trenching. And then since the nucleus is very, very large, we make multiple pieces. It is important to know that you are chopping it through and through. As you can see, these are the posterior interdigitating leathery fibers. So they need to be separated. When the nucleus is so bulky, instead of making 4 pieces as in stop and chop, multiple pieces are made and you see the rotation is in one place. Now, when you aspirate one of the pieces, you are debulking it and then you rotate and each piece is aspirated. A good viscoelastic is used here, as you can see over here. Now, this is the second case, again, a white cataract and a superficial cortex is removed. The tip is embedded and with the chopper, the cataract is directly chopped. The good holding is very important of followability. As you can see over here, this is how it is done. So this is the phaco probe and the direct chop. So you have to be very careful to use the correct ultrasonic energy in a direct chop, because if you're not doing it, you may cause zonular dialysis or you may, so it is very important to have good control. The importance of this direct chop is that you are saving the energy of ultrasound by which otherwise you would have used during the trenching. So this is used in direct, in very hard cataracts to emulsify the nucleus. Here only 4 pieces have been made. Now this is the second part of the nucleus which is now rotated and brought down and again chopped directly. So this is one of the techniques of phacoemulsification, which is also known as a Nagahara chop. As you can see here, the cataract is very, very hard. There is hardly any epinucleus and one needs to have a complete and a nice machine with complete followability, which means that the ability of the probe to hold these hard nuclear pieces. One must remember to wait for a second before going out because otherwise there will be a surge. In cases of soft cataracts, you think that the soft cataract is very easy, but sometimes no single technique may work and you may try to use any of these techniques or a combination of technique to tackle the cataract. Now, what happens is in the cataract is so soft. As you can see, this is a posterior polar cataract and the cataract is very, very soft. You do only hydrodelineation. And now you can see over here that if you try to chop, it will be very difficult. So what you do is you lift the cataract as a whole and then phaco 2, where you are using more aspiration than phacoemulsification, this whole nucleus is emulsified. So once again that we see that the nucleus is flipped like this and it is emulsified. Because we have done only hydrodelineation in this patient, the soft epinucleus remains. Why this is necessary, as we'll see in this case, that if you try to chop it, the nucleus is so soft that the crater effect occurs. And you may sometimes chop directly and to the PC because the nucleus is extremely soft. And this is like a crater or a ball effect. And if something like this happens, what you have to do is carousel the nucleus, lift it from one side, as we will be seeing now. We don't want this saucer effect to occur. So it's better to do it in like the previous way. But if it still occurs, as you can see, this is rotated and from the equator, this can be emulsified as a whole. So, it is very difficult to chop soft cataracts and to avoid any difficulty, these techniques are used. The epinucleus, as you can see over here, still remains. So this is the third technique, which is a chip and flip. So as you can see, this is not a posterior polar cataract, but a soft cataract. multiple points of hydrodissection are used because you don't want fluid at one place, which is safe, which does not cause the bag to get filled with fluid, and there may be a small defect or something like that. As you can see, this is a nuclear solute where the nucleus is lifted slightly and it is completely emulsified as a whole. In the video, it can be seen that it is so soft that only aspiration is used. No ultrasound is required. This is in phaco 2. And the epinucleus can be tackled either in the epinuclear mode or with the AC maintainer and the side port, as we are using the Laney's cannula. So it can be managed in any way. So soft cataracts, though they look very, very easy, they can be very, very dangerous. This is the management of the nucleus. You can remove it in the epinuclear mode or with the AC maintainer and the. So some, so one more case where we'll see stop and chop. So this is a grade 1 to 2 nucleus where there's a nicely dilated pupil and it looks very soft cataract, but it is possible to do the standard Paul-Cox stop and chop. Now in this, the first division is very, very important, where you make 2 pieces of the nucleus. So this is a central groove, which is the standard thing which we follow in most of the cataracts, and it is a reproducible technique, a technique which can be easily learned, it can be taught. This is the first division, which is very, very important. But if this goes well, it is likely that the phaco will be uncomplicated. Then divide it. Again, stop and chop. This is the 4 parts of the nuclei, which will then be aspirated in the phaco 2 mode. This is the most commonly used technique by most of the surgeons, and it can be applied to most of the cataracts that we are faced with today. And it is a safe technique. It can be easily learned and it can be easily performed by surgeons, all trained and beginners. So this is the standard stop and chop technique which we know. This is the nuclear piece, which is, though it looked very soft, it is a grade 1 to 2 plus cataract. So these are the various techniques that are performed, and any other thing which is good in your hand. So what is important is to do what is safe. Don't leave the safe zone, which is the central zone during phacoemulsification. Maintaining the anterior chamber, knowing the machine and the fluidics, and keeping the patient first always is the most important thing in the life of a surgeon. Thank you, Namrata. Thank you, everybody. It was wonderful to hear the presentations and wonderful to spend time with you, Namrata. Sorry, Prashant, I hope you catch a flight and have a safe journey.
Thank you, madam. Thank you.
Thank you, Ragini. Thank you,
The
sir.
target before you. That's why I said, I have another 15 minutes to catch. Now I will just leave the hotel.
Okay.
Thank you.
Thank you,
so
Ragini.
much.
Thank you so much. From a camp, I know you are in a remote place. Thank you so much. And thank you so much.
It was a wonderful camp. We have done 575 surgeries and we are discharging the last 230 patients just now after this. Thank you, Namrata. Thank you so much. With your permission, can we leave?
Sure, please. Thank you, Ragini. Thank you, sir.
I'm also returning from a camp. That's why the signal is so bad. And returning from
Hi,
Siwan to
Satyaji.
Patna. Hello, ma'am.
Hi.
Prashant.
अच्छा प्रशांत बस आपका फ्लाइट है तो आप बोल लीजिए पहले.
Yeah, thank you. Thank you, Satyajit. Okay. Can you see my slide, ma'am?
Yeah, very well, Prashant.
Okay. So thank you, Namrata madam, for this wonderful opportunity. At the outset, I would thank the whole society, and basically this is in fact a tribute to the 2 Irish genius, that is Amar Agrawal sir and Priya Narang madam, who have really revolutionized and has inspired us to do all these things. So iris is why I've labeled this slide as forgotten, is basically because iris is the tissue which is most disrespected by be it an anterior segment surgeon or a posterior segment surgeon when it comes to rehabilitation or a reconstruction of an anterior or a posterior segments thing. What happens in a trauma, call it a iatrogenic or call it a routine trauma, iris is excised because of the lack of its understanding, because of the fear of infection and sympathetic ophthalmia. And that's why many a times you will see a pupil like this, a mydriatic pupil, irregular pupil, a disrupted or an aniridia, which is not so uncommon in a post-operative picture. And what that means is these patients end up having a glare, visual disturbances, photophobia, in spite of having a good pseudophakic rehabilitation. And importantly, the cosmesis, the eye, the beauty of the eye lies in the pupil and the iris diaphragm. And if you means that damage that iris tissue or you don't repair it, it means a psychosocial impact on that young person who faces it. Now, this is a video bouquet of few of the cases, how it can be managed. Now, this is a case of a traumatic a surgical aphakia operated elsewhere. We hardly could see the iris tissue, which is present in this quadrant. We thought there is a huge loss of iris tissue. And so after doing a phaco-IOL, or rather SF-IOL, here with the help of a vitreous forceps, I am under viscoelastic through the side port. I am trying to analyze or unravel the iris tissue which is rolled back. And to my surprise, there is enough tissue which was rolled back because it was retroflexed iris. So now I decide to approach these two iris by 4-throw knot pupilloplasty with a tinoprolene suture. The suture goes from 7 o'clock, engages the iris at 7 o'clock meridian, then engages at 5 o'clock and comes out through the 5 o'clock side port. And so once that is done, then we create a knot, as already Dr. Narang has shown us. Well, once the knot comes out, there are 4 throws are taken. And once the 4 throws are taken, you just have to tighten the things. And there will be the approximation of the iris between 5 and 7 o'clock. The same procedure is repeated at 10 and 2 o'clock meridian. And this is the end result of it. This was the case pre-op, and this is the pupil, which you can see some time later. Now, this is another case of a young patient with a 180 degrees disinsertion of iris root with a traumatic cataract. Here we wanted to do phaco-IOL with iris repair. Naturally, the iris root which was disinserted had to be anchored back to the scleral tissue. And so after doing phaco, we needed to. But while doing phaco, you need to keep this iris tissue away from the active ports of irrigation aspiration or a phaco, otherwise you will chop it off. So I'm using an iris hook first to get it out of my way during the phaco surgery using an iris hook. Once that is done, you can see I have done a phaco and I put the lens in the back. Now is the time for me to repair the thing. So I cut a conjunctiva, create scleral grooves over there because tenoprolene suture should be buried. It should be intrascleral. And this is what it goes through. Tenoprolene suture goes through at one point and comes out through other, and it is anchored. Now, when I realized this, that the whole iris is bigged over here. So I needed to create a small pupil. So naturally, the option is to combine it with a 4-throw knot pupilloplasty. And once we do a 4-throw knot pupilloplasty with iris root anchoring back, rather I should say, this is the end result of it. You can see the near normal pupillary size and the shape of this patient, and the iris root will anchored back. Another extreme case of a thing where you can see that the iris root disinsertion was there as well as iris tissue. So we had an iris tissue up to 7 o'clock, 7 to 11:30, there was no iris tissue left. So first my job was to anchor this rolled up iris over here. So here I'm going to use a tenoprolene suture and anchor it at first at 7 o'clock. And this, with a tenoprolene suture. And once it is anchored over there, then I realized there is one more iridodialysis, quite a significant thing. So I again repair it here and anchor back the iris root again back at 5 o'clock meridian. And then after doing this insert means anchoring back of the iris tissue, now I will approximate the available iris tissue to compensate for the iris tissue loss between 7 and 11 7 o'clock to 11 o'clock meridian by doing a 4-throw knot pupilloplasty. So now I do a 4-throw knot pupilloplasty, but that meant that there was a iridodialysis between this because there was hardly any tissue. So again, I do an iris root anchor repairing. And so these are multiple procedures which are combined together in such extreme cases. And this is the post-op picture of the same patient who had not only had a cataract rehabilitation done, but also an iris repair done. Another extreme case of a traumatic vitreous hemorrhage with a traumatic dislocation of a cataract with a iris tissue loss. That is what we initially thought. So after having done a vitrectomy for this and a lensectomy, here I am with the help of a forceps trying to assess how much is the iris tissue available and what is the type of a trauma. And to our surprise, it was, fortunately for us, it was the iris diaphragm which was retracted. It was a long-standing case when it came to us. So now it was a very friable iris. So it meant we had an iris diaphragm, we had a pupil, we needed to just anchor back the iris root, which was disinserted. And same was done with a tenoprolene suture at 2:30 meridian, then repeated at 1 and 5 o'clock meridian. And you will see the end result of this. Again, the same patient, he has a beautiful IOL along with a circular pupil in even such a mutilated globe. Now, this is the last case of this video, Blue K. This is a trauma. In fact, an aniridia with a cataract. In aniridia, the poor vision is because of foveal hypoplasia, but as well, the patient has a lot of photophobia and a nystagmus. So creating a pupil or cutting down the light which is going on by use of aniridia IOL will definitely make his life more palatable and easy. So here, what we do differently is after doing a phacoemulsification and IOL, this rigid IOLs, which are single piece, we do an anchoring of it like a scleral fixation. Instead of just putting a suture and let it hang into the antechamber, we usually prefer to do like a glued IOL. So here I am doing a phaco side ports. I think I will just forward to this part. And remember, this aniridia IOL are rigid. They have to be customized, and their optic size is almost 12 millimeter in size. So while after doing phaco, I'm creating a vitreous, means I create an infusion cannula because there will be a lot of hypotony which should be taken care of, and an incision as big as 12 millimeters created. The optic is put, and then the haptics are externalized through the ports, and then it is buried into the scleral tunnel, subscleral. So once you do an anchoring of this patient had a very nice circular pupil-like structure. You could cut down because of the iris aniridia IOL, the light entering into it, and he had a real palatable vision. So friends, just reconstruction of an eye by doing a IOL or doing a vitreous surgery is not enough. Many a times, if you do more, just by creating a pseudo-pupillary diaphragm or with the available tissues, the patient's life definitely becomes more palatable. Thank you once more, madam, for this wonderful opportunity.
Thank you, Prashant. You are a posterior segment surgeon and you manage iris so well, better than anterior segment surgeons also. Thank you so much for those wonderful videos. I hope we have relieved you in time to catch
Yeah,
up.
I was just now rushing back.
Thank
I'm in
you.
Kochi. Thank you.
Okay. Thank you. And now I would request Dr. Satyajit Sinha. Satyajit, who's also...
Ma'am,
let's hope.
can you hear me?
Yeah, let's hope this time it works. Please share your screen.
Ma'am, can you hear me?
Yes, Satyajit.
Okay, so I was talking, once again, I'd like to thank Dr. Namrata Sharma for this opportunity. I was talking the injury to the lens may lead to ocular disorders through various mechanisms. We have to remember that these are the patients who were until yesterday or before the trauma were seeing absolutely well, and their expectations are very high when we are treating them. So we can have phacomorphic glaucoma, the anteroposterior diameter of the lens swells to such a degree that it occludes the iridocorneal angle. There may be subluxated or dislocated lens. Dislocated lens can move forward, resulting in narrowing of the angles. If the lens capsule is ruptured, lens protein can impair the aqueous flow either directly or by clogging the trabecular meshwork, lens particle glaucoma, or by causing an inflammatory response in the anterior chamber, phacoantigenic glaucoma. Now, pre-surgical considerations which we have to take before taking up these patients are to determine whether the traumatic cataract is secondary to penetrating or blunt trauma. Once penetrating trauma has been ruled out, ultrasound A and B scan may be used to further assess the ocular status, and ultrasound biomicroscopy may be used to visualize the posterior capsule. Pre-operative evaluation also includes a simple X-ray to CT scan. If you're not sure of what the foreign body is there inside the eye, MRI is not recommended, because if it's a metallic piece, then there'll be more destruction in the eye. OCT of the posterior capsule, anterior segment OCT, as Dr. Mahipal was saying, is also good in evaluation. And we do a gonioscopy, B scan, and OCT of the macula are helpful in giving a prognosis. Significantly low intraocular pressure should always raise a suspicion of an open globe. However, in some cases, the wound cell seals and IOP may be normal. If penetrating trauma is present, the use of topical medication or devices that touch the eye should be avoided. And external pressure on the globe may cause extrusion of intraocular tissue, and environmental pathogens may lead to severe infections. Patient systemic health is also important, and the choice of anesthesia that we are going to use according to the status of the patient is very important. As aseptic and antiseptic procedures, the preoperative cleansing and sterilizing of the ocular area should be performed carefully and gently as possible to avoid further damaging the eye structures and introducing bacteria into the eye. Laceration or loss of corneal tissue may be present, and we should suture this with 10-0 nylon. And especially in pediatric cases where the corneas are more elastic, it's preferable to close the wound with higher tension rather than just opposing the tissue. One of the things which becomes more difficult in these patients is IOL calculation. A lacerated or traumatized cornea severely compromises the IOL calculation, as it may be impossible to obtain an accurate keratometry. And at times we can take the help of the other eye to make an IOL calculation if it's very difficult to do it in the traumatic eye. In anterior capsule and zonules, use of capsular dye such as Trifen Blue helps the surgeon to visualize the anterior capsule in order to assess its condition and control it more easily. In non-ruptured anterior capsule, if the anterior capsule is intact, a standard continuous CCC 5 to 6 millimeter in diameter can be performed. And we have to handle the anterior capsule gently because we are not very sure of what is the status of the zonules. When the anterior capsule is ruptured, a lens becomes opacified in course of hours or even minutes. Usually it indicates a ruptured anterior capsule, which allows the lens fibers to become hydrated with aqueous humor. If the rhexis cannot be completed, the surgeon should make a cut with Vanna scissors to avoid pulling it with the emulsification handpiece or irrigation and aspiration tip. For zonule weakness or dialysis, the surgeon can place the iris or capsular bags to secure the bag from the cataract extraction. Capsular tension rings are if is present for more than 30 to 90 degrees of the absence of rhexis, or if posterior capsule is, it has run away. In purely traumatic, lens nucleus can be easily aspirated with the irrigation and aspiration. But if there is a combined senile component, then that factor has to be put in the surgical plan. Especially in these cataracts, when we are doing the parameters during phacoemulsification have to be low, and ultrasound power varies depending on the hardness of the cataract. Intracameral antibiotic is a good idea to use at the end of the surgery. And to control the bleeding during cataract extraction, dispersive viscoelastic may be used for tamponade, or intracameral epinephrine may be injected to cause vasoconstriction. There may be vitreous prolapse during these surgeries, and complications such as retinal detachment may occur if the vitreous is heated or pulled with the phaco handpiece. So in that case, combined vitrectomy also has to be done. If there is hyphema, the blood is present in anterior chamber, it should be washed out or removed as soon as possible because of the risk of corneal blood staining. And during cataract extraction, bleeding may occur spontaneously. To help control the bleeding, dispersive viscoelastic may be used to tamponade. The type of and optimum placement of IOL depend on the clinical context. If visualization is poor, consider placing an IOL in the secondary sitting, in the next sitting. If the capsular bag is complete, a single piece acrylic IOL is usually placed in the bag. However, if the capsule is ruptured, a multi-piece acrylic IOL should be placed either in the capsular bag or in the ciliary sulcus. After closure, the surgeon should assess the leakage and ensure that all the wounds are sealed. However, it may be a good idea to put air in the anterior chamber to see if it's leaking or not. These are the references. I wanted to show a small video which I'll just share. this is the this patient came with a trauma to the eye. You can see there's a posterior synechia at the point where there is a trauma. So we make a paracentesis and we fill the anterior chamber with viscoelastic. We make the main incision, and we have to gently, once you make the anterior chamber, then you fill the anterior chamber. Once you make the main port, then you fill the anterior chamber with viscoelastic again, and gently you have to snug it in such a manner that the iris also doesn't get pulled off from the other side. And then we remove the debris which is there on the iris margins. Once we have removed the posterior synechia, now we have a better visualization. And as I was saying, in these cases, sometimes when you are not sure what the foreign body is, we should not do a MRI. As in this case, we could not see what it is. But once we took out the piece, it was a metal piece which was there just behind the anterior capsule in the anterior chamber, inside the lens. Now, when we are making the rexis in such cases, I'll forward it a little bit. We should go from around the place where the entry has been made by the foreign body, so that a continuous curvilinear rexis is there for us to complete the phacoemulsification. So this is it's completed. This is the thing which I wanted to show. I'd like to thank Dr. Namrata Sharma ma'am for the opportunity in giving me to speak on this traumatic cataract.
Thank you, Satyajit. Despite the fact that there were connectivity issues, you still gave your talk very nicely. And also the video was shown very well.
Thank you so much, ma'am.
So much, Satyajit. Thank you, everyone, for this wonderful session. And with this, we come to the conclusion of the 3-day Aios International Ophthalmology Conclave, which involved 22 international societies, 500 plus speakers. And the link was given to all the 22 countries. So the exact figures for the international delegates would come in soon. Thank you very much. I would also like to thank the backend team of Mr. Nimit Soni, who has helped to make this platform, and would also like to thank profusely our Aios headquarter team, which includes Mr. Kripal, Mr. Sajid, Mr. Madhu, and everybody in the Aios headquarter who has made this possible. Of course, Mr. Kripal Rana is the backbone of the communications that have been sent to you, and thank you very much. So thank you, and hope to have you again on and see you again on another platform. Thank you very much.
Thank you, ma'am.